Arise, awake, and stop not until the goal is reached. With these inspiring words of Dr. Swami Vivekananda, I welcome you all to the second edition of the International Conference of Craniofacial Pathology and Biology. I am Dr. Abhilasha, Professor from the Department of Oral Pathology, and I'm really happy to be hosting this inaugural function. This is the second consecutive year of this conference, which aims to strengthen the science and current research in the field of craniofacial pathology and biology. I stand today among a scintillating galaxy of oral pathologists, stalwarts in our field, and it's truly an honor that all of you are here to grace this occasion. Savita Dental College, as all of us know, is the #1 college in the country, and we stand 13th in the world. And recently we achieved a milestone of crossing more than 10,000 publications in Scopus, superseding the Harvard University. Now for a short achievement video of our college of last year.
Hey! அங்கேருந்தா பாரு, இங்க மட்டும்தான் பார்க்கணும். ஹொக்கோம், டைகர் கா ஹொக்கோம். ஹொக்கோம், டைகர் கா ஹொக்கோம். Raja di Raja.
Thank you. Now I request our dignitaries to be escorted to the dais. First of all, I would like to call upon our advisor, sir, Dr. Rajagopal, sir, to be kindly escorted to the dais. I invite our registrar ma'am, Dr. Shija Verghese ma'am, to be escorted onto the dais. I invite our guests of honor, Dr. Jagdish Vishnu Tukkari sir, Honorary Professor GDC Mumbai, to be escorted onto the dais. I request Dr. Ranganathan sir, Honorary Secretary of the IAOP, the International Association of Oral Pathologists, to be escorted onto the dais. I request Dr. Shivapada Sundaram sir, the Dean, Priyadashini Dental College, to be escorted onto the dais. I request Dr. Nadeem sir, Honorary Secretary of the IAOMP, to be escorted onto the dais. I request our very own Dean sir, Dr. Arvind Kumar sir, Dean of Savitri Dental College, to be escorted onto the dais. We shall now begin today's formal proceedings by invoking the blessings of the Tamil goddess. I request everyone to kindly rise for the Tamil Thai Varthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Light signifies knowledge, and lighting of the lamp is regarded as a bow down to knowledge. With this knowledge, we expel the darkness of fear and ignorance. So now we will have the lighting of the Kuttu Velakku. But if all of you are wondering where is the Kuttu Velakku, now this is the digital era. So we will have a digital lighting of the Kuttu Velakku right now. May the light of this lamp illuminate our path and guide us towards the knowledge and wisdom we seek. Now, I request our most enterprising, our mentor, the most passionate and sought after oral pathologist, head of the Department of Oral Pathology, Dr. Pratibha Ramani ma'am, to kindly give the welcome address.
Good morning to one and all here. Actually, Abhilasha is over-exaggerated because I'm in front of most of my teachers here, and it's because of the blessings of my guru and my teacher, Dr. T.R. Saraswati, and the galaxy of teachers who are here. I am what today. So, so this is, what can I say, a respectful thanksgiving to all my teachers, and most of them who are here are my teachers. Thank you one and all. On behalf of Savitri Dental College, it's always been my proud privilege to welcome each and every one of you, because this institution is built by the visionary who has, and who is still having a very long dream to make the field of dentistry you take further ahead in the world. So already we have reached number 1, and it's none other than our Chancellor, Dr. N.M. Virayan. He is very much in the campus, but due to certain circumstances is not able to come here in this function, but I'm sure his blessings is very much a part of the function here. And so here we have his most trusted, like it's almost like sir who is here, our advisor, Dr. Rajagopal sir. We welcome you, sir, for coming and gracing this occasion, because it's like having sir here when we see you here, and we are really honored to have you here in amongst us, sir. And of course, the most important dignitaries are our Registrar Ma'am, Dr. Shija Varghese, and our Dean, Dr. Arvind, because they are the pillar of support. They always stand by all our endeavors, and Shija Ma'am has a smiling face, and she peps up all of us. The day in the morning starts with her smile. And of course, our Dean, you saw the Rajinikanth song behind, it is his idea. So he's like the Rajinikanth of our college. So we welcome both of you, sir. But the most important, like on behalf of the dental college and on behalf of the university, it is actually a proud privilege to welcome the 4 stalwarts who are sitting on the stage here. And as I mentioned to you, all of them, probably Nadeem is maybe a couple of years my senior, but all of them are my teachers, and I consider them as my teachers. Dr. Tutkare sir, he has been the professor and head of Government Dental College, Mumbai, and sir is a very soft-spoken but highly knowledgeable, and he has his tree of students spread across India, and it's indeed a proud privilege for Savita Dental College to honor you, sir, and we welcome you, sir. We also have the privilege of welcoming Dr. K. Ranganathan. I think most of us here are very much aware of sir. Sir is the Honorary Secretary of International Association of Oral and Maxillofacial Pathologists. I think sir is the first to be heading this post, and I think it's a proud moment for India to have an Indian representing all the oral pathologists across the world, and we are really proud of this achievement. And one more interesting fact is, sir is, all of you are aware of the UG students, sir has been trained by Dr. Allen. So I think that is an important fact which all of you may relate to, the undergrad students may relate to. Thank you so much, sir, for gracing the occasion. The person next is Dr. B. Shivapal Sundaram. Sir is fondly called as SPS sir, and he is the author of Schaefer. So Schaefer textbook of oral pathology, and I think it's again a big moment, like a person who has taken up to an Indian edition, or like still I don't think around the world there's an edition, but sir has taken the efforts to revise the Schaefer, which was long pending, and it's actually a treat for all of us to read the book. So thank you so much, sir, and of course he's the Dean of Priyadarshini Dental College. I'm also very happy to welcome Dr. Nadeem Jetty. He is the professor and head of Thai Mugambika Dental College Oral Pathology Department and Secretary of Indian Association of Oral and Maxillofacial Pathologists. So we have 2 persons representing almost the Indian oral pathologists and the international oral pathologists who have graced this occasion, and we welcome both of you, sir. Thank you so much. Of course, in the we have a galaxy of almost all the HODs from Tamil Nadu and Chennai who has graced this occasion. And of course Dr. Murali, who has come all the way from Bangalore. He's always, though as a conservative dentist, always been a part and parcel of anything which is related to craniofacial biology. Sir is there. Dr. Satish Muthukumar, Dr. Satish, Dr. Aravind, and of course another teacher of mine, Dr. Malti ma'am, Dr. Shamla ma'am. I think most of the Savita students and of our visionary, I was the last to go to tell, but I would have to tell here, our director, like who is the Savitas, all this because of the high vision of our director, Dr. Deepak Nalaswamy. He is the soul behind all the success which Savita is happening. The father son is like, it's the trend is only going the upward skin, and ma'am has been the teacher. Dr. Shamla is teacher of Dr. Deepak Nalaswamy, and I think he keeps mentioning that whenever I go and meet sir. So I think all of us are aware of that. So welcome ma'am. We also welcome Dr. Malti ma'am. She's a senior oral pathologist in India, and we are really honored to have you ma'am. Dr. Kavita, professor and head from Meenakshi Ammal Dental College. Dr. Shivakumar is a first batch student of Savita and now currently heading Mada Dental College. And we have, of course, Dr. Kritika, again, another conservative dentist here. Dr. Satish Muthukumar, he's heading professor and head from Chettinad Dental College. Dr. Sai Krishna, he's heading Mada Dental College. And we have Dr. Yolita, who's come all the way from Vivekananda Dental College. He's come from E-Road. So we have, I hope if I have missed anybody else in the crowd, please forgive me, but I welcome each and every one of the heads and the professors from various institutions across Tamil Nadu, and all the postgraduate students and undergraduate students who have come all across from Tamil Nadu and few from other states also. So we are indeed fortunate to have all of you here, and we and hope to have a fruitful session here at Savita Dental College, and hope you have a good time in the institution. Welcome all of you. Thank you so much.
Thank you, ma'am. I once again welcome you all. Your presence elevates the significance of this conference. Now, I would like to request our advisor, sir, Dr. Rajagopal, sir, the previous Vice Chancellor, and he's a teacher of teachers. He's been the head of the department and the teacher for our own Dean, sir, as well. So I welcome you, sir, to address the gathering.
Yeah, very good morning to everyone. It's a great pleasure to attend this international conference of the oral pathology and oral biology also. And indeed, when we studied at the time, it's called only oral pathology, not more than that. Now the knowledge is widened and the field is also widened very much. And there is sitting all the galaxies of the oral pathologists are there. Of course, students are there. I think they will be immensely benefited by the outcome of this oral pathology conference. And in this juncture, I would like to compliment our Chancellor and Dr. Deepak for their vision and, to bringing up the institution to this higher level. I wish this World Pathology Conference a grand success. Thank you.
Now I request sir to be honored with a bouquet. Now I request our head professor and head of the Department of General Pathology, Dr. Monal sir, who is a very quiet person but very effective person. I request him to kindly introduce our guest of the honor, Dr. Tukkari sir.
Good morning to all the dignitaries on the dais, and all my students. I think it's a very unforgettable moment for me to introduce the sir, because sir was, and I feel he is a guide for me forever as a individual also. So to introduce the sirs in such a short time is like a drop in the ocean, but I will try to briefly introduce the sirs as I know it. I don't need anything for that. Sir was born in small town in 1955 in Maharashtra, and that is way long back. Sir completed his BDS from GDC Nagpur in 1976, completed his MDS in 1979 from GDC Mumbai. Since then, Sir has been associated with the Government Dental College for till his retirement or superannuations. Sir was head of the department in the GDC Aurangabad, GDC Mumbai, and he was also Dean GDC Mumbai, and then became a joint director Maharashtra Dental Education System. And he worked there for so many years, so you can imagine how much he has contributed to not only just oral pathology, oral biology, but also in the field of the dentistry. Under his guidance, several students have passed out, and now they are heading many of the dental colleges, departments, and not just in academics, but they are also in the research. So you can imagine how much contribution has Sir done in that. He has also contributed several papers in scientific journals, both at national and internationals. Also, he has received several awards at the national and international levels. He was also very much part of several academic committees in the institutes as well as the universities. I welcome you, sir. Thank you very much for coming here, and it's really an honor for me to introduce you, sir. Thanks. Now I request sir to speak a few words.
Honorable Sri Ram Gopal sir, Vice Chancellor of the University, other dignitaries on the dais, the Registrar of the University, Srija Madam, Dean, Savita Dental College, Dr. Arvind, and of course my colleagues and friends, Dr. Ranganathan, Shivapal, and Dr. I see many of senior professors in the audience, and of course my young friends. It is a great pleasure for me to be with you amongst this gathering. And to say on this occasion, I have attended oral pathology conferences, but this is the first time I am attending the conference of oral pathology and oral biology. Now this is something unique, and it will have a long way to go, because I strongly believe that if oral pathology has to be understood, one has to understand the basic science of oral biology, dental histology, and so on. Unless your foundation is good, you cannot do much more in oral pathology, and that is the very challenging one. And of course you have taken this initiative. I congratulate all of you for taking such type of initiative. Of course this is the second conference, but many more will come in future. Whatever today I am is because of all stalwarts from whom I have learned. To name some of them, Dr. Lele, sir, my guide, postgraduate guide, and of course then there are many. Dr. Dholakia sir is there, Dr. Vishwanathan, of course they are not now in this world, Dr. BVG is there. Like this, so many senior faculty members to whom I knew personally or I had interactions with them, and I learned not only oral pathology but the way of life of them. And of course that I tried to follow them to certain extent. I think I could do it, not to the 100% what they had expected probably, but I always used to say that yes, as a teacher, you teach the students, you guide the students and all these things. But as a postgraduate teacher, I used to say that I have 9 students, because we had 9 admissions in the department, and every time everyone used to come with some other problems, and I learned something from them, from each one of them, and that is very important one. So there has to be interaction between the teachers and the students, and if that is positive, if it is taken in both the ways, from the students also it should be positive, taken in a positive way, and from the faculty also it should be given in a positive way, that yes, we are there for the betterment of the students and not to harass them or not to you can say bother them, something like that. Only academic activities, and if you inculcate some knowledge, some basic principles of knowledge, and some moral guidelines, I think that will help for the future generations. With these few words, I thanks all the organizing committee members, the chairman, and the colleagues, those who have invited me for this conference, given this opportunity. I thank you once again, all, one and all. Thank you very much, and of course, I thank you all who have listened to me. Thank you.
Thank you, sir. It was great to have you here, sir, among us. So now I request our head of the department of admin, Dr. Karthikeyan, sir, who really is also the associate dean of audit of our Savitri Dental College. He audits everybody, and he's the most eminent organizer of our college, and I'm very happy to have sir here, and I request him to kindly welcome our other guests of honor, Dr. Ranganathan sir and Dr. Shivapada Sundaram sir.
Good morning, everyone. To all the dignitaries on the dais, all the staff and my teachers, and the faculty members, the students who have come here from across the state. So it's my honor to welcome everyone for this second edition of our international conference. So my first felicitation will be for Ranganathan sir. His CV is pretty long, and try to summarize it in few words. As sir has lot of laurels which we can speak for a day. So for now, what I would like to summarize is sir did his VDS, MDS and PhD from the Tamil Nadu Dr. MGR Medical University. Sir has also done his MS from Ohio University, US. Sir is also a fellow of American Academy of Pathology and a fellow of Indian Association of Oral Maxillofacial Pathology. We are proud that an first Indian oral pathologist is heading the secretaryship of our International Association of Oral Pathologists. And sir is also a past president, honorary secretary of our IOMP. Sir is also the past president of Asian Society of Oral Maxillofacial Pathology. And sir is a well-renowned speaker across the globe for various topics, especially in HIV and in OPMDs. And it's my privilege to welcome you, sir, for our gathering. Thank you, sir.
A very good morning to you all. Respected advisor Dr. Rajgopal sir, he was my teacher too. It's nice to see you after a long time, sir. Respected Registrar Dr. Verghese, respected Dean Dr. Arvind, the guest of honors Dr. Tukkari, Dr. Shivapada Sundaram, Secretary IOMP Dr. Nadeem Jetty, my colleague Dr. Pratibha, who's standing at the back, but I think you should be in the front, who's the key person for this event, the management of Savitri Dental Institutions, and all the colleagues of the dais from my specialty and other specialty. Nice to see familiar faces, and participants of this international conference on craniofacial pathology and biology. It's a pleasure to be here today, and let me thank Dr. Pratibha for having extended this invitation. I must confess that when she called and told me take part in it, I wasn't expecting to sit on the dais. Thank you for that honor. Thank you very much. Just only one thing I would like to add to what she said. Before Dr. Allen was my teacher, Dr. Saraswati was my teacher, and she was my teacher for both masters and my PhD, and I was the first PhD and master's student actually. So I had that unique honor of being a student on both. I did see the invitation and it said 2 to 3 minutes to talk, and I'll stick to that. Just one thing I'd like to confess, I'm very envious of all the participants of this conference. It's really amazing that you can have this galaxy of eminent speakers at one place and listen to all of them at one venue. This was not possible about 10-15 years back, and Dr. Tukkari would agree with that. We need to go travel abroad, we need to travel multiple conferences to get this cumulative knowledge experience. So I urge you all to make the best use of it. And let me emphasize with what Dr. Tukkari said, you need to interact. Make good use of this excellent speakers that you have. Please do interact with them and go back not only with knowledge, but with networking, your other colleagues from other institutions and from different parts of the country. Please do network with them. And I think you will go back with a very rewarding experience. Let me stop here once again and thank you for extending this warm invitation. Thank you very much.
So I'm back once again to felicitate the other guest of honor, Shivapada Sundaram sir. So sir is also again a very large CV with multiple laurels to his credit. So to summarize sir's achievements, sir did his BDS and MDS from Government Dental College under Tamil Nadu Medical University. So sir was the professor and head of Meenakshi Ammal Dental College. Then sir went on to become the principal of Meenakshi Ammal Dental College. Then he became a vital administrator, becoming the registrar and even pro vice chancellor of Meenakshi Academy of Health Sciences. Then now sir is currently serving as the Dean of Priyadarshini Dental College, Tiruvallur. Sir has also been the editor of prestigious journals in India and international journals as well. And sir is the well-renowned editor of the Schaeffer's edition along with Rajendran sir. And now currently sir is working on the upcoming editions of Schaeffer, which we all follow. And it's my privilege and honor to felicitate sir for this event. Welcome sir.
Respected dignitaries on and off the dais, wish you a very good morning. And this gives me immense pleasure, and it's an honor for me to attend this conference. As Dr. Tuppari rightly said, pathology does not exist without the existence of the basics like the biology. So once it was an oral biology, now it is expanded to the craniofacial biology. And it is very surprising and special to know that Savita Dental College is having a separate faculty for this oral biology and craniofacial biology. And about Savita, whenever I come here, I take some message and try to implement in our college. And this time it is digital Kuthuvaluku, the eco-friendly and innovative one. And about this conference, eminent speakers are going to give lectures. There will be a lot of exchange of knowledge, ideas and experiences. I hope the participant will get benefit out of it. I wish the conference a big success. Thank you very much.
Thank you, sir. Now I invite Dr. Ramya ma'am, the professor and head of oral biology, the initiator and executor of most of the programs in our department, and of course the backbone of this conference. And she's also the associate dean of extension activities and ardently executes all the conferences in our college. I welcome you, ma'am, to introduce Dr. Nadeem sir, the honorary secretary of the IAOMP.
Thank you, Obi. Most of them are not true. Thank you so much, and I'm here to introduce Professor Dr. Nadeem sir. He is a professor and head of the Department of Oral and Maxillofacial Pathology of Thai Mogambige Dental College. I'm so humbled and honored to have you here, sir. Dr. Nadeem sir is a very highly proactive personality in our specialty. He has been strongly representing our region, South region, in our National Association of Oral and Maxillofacial Pathologists for more than a decade now. So we really are very thankful about it, and we are really honored to have you, sir. Nadeem sir is also a very avid academician. He has various national and international publications to his credit. I invite you to give us a few words, sir. Thank you.
Very good morning, one and all here. Dignitaries on the dais and off the dais. It's indeed an honor and privilege for me to be here today. Amongst the stalwarts here sitting here, most of them are my teachers, Dr. Ranganathan sir, Dr. Sirpadasundaram, Dr. sir, Director Arvind, and all the seniors sitting here, Dr. Malati. So I take this opportunity to thank Pratibha Ramni, Ramya, and all the other staffs of Savita for having organized such a wonderful conference. And like Dr. Sirpadasundaram said that we always learn from Savita. There are a lot of things which we take home message. So like I wish this conference a grand success. Thank you very much.
It's a kindly accept a small, beautiful flowers to welcome you amidst our gatherings.
Thank you, ma'am. Thank you, sir. Now I would like to welcome a few of them who ma'am has missed. So I welcome Dr. Sai Krishna sir, who is the head of the department of Tagore Dental College, and I welcome Dr. Arvind Babu sir, who's always been a friend to us and always been supportive to us, the head of the department of Balaji Dental College, and Dr. Rajashri ma'am, who's been an ardent research collaborator for our department from the Madras University. I also welcome Jayanti ma'am, our alumni and very active oral pathologist in the association, head of the department of Azizia Dental College, Dr. Vijay Lakshmi ma'am from Adyar Cancer Institute. Ma'am is like an eminent scientist, and we are proud to have you here, ma'am. And also the other staff, faculty from the other colleges who have taken out their time and are with us today. And I would like to Simranjeet Singh sir for coming all the way as a speaker for our conference. Thank you, sir. So I would now invite Dr. Geena ma'am, who is a professor of our department. She is one of the pillars of support of our department. I invite ma'am to kindly introduce our dean sir and registrar ma'am, who will be offering their felicitations.
The beautiful, elegant, and an ageless persona who is with us with an ever-smiling countenance. Many of us will know whom I am talking about. Our registrar, Dr. Sheeja Verghese, who is Sheeja ma'am to us, is a woman power. Okay, she is like the right blend of iron resolve and calm demeanor. She is a blessing to us in many ways. She has finished her BDS and MDS from Government Dental College, Trivandrum, and has been with us for almost 25 years now. She has an enormous teaching experience and is a much loved teacher, and she has numerous national and international publications to her credit. And most recently, she has been awarded the Research Collaborative Project from ICMR for her work on lactobacillus species on membrane vesicles. We welcome you, ma'am. It's been an honor to welcome you. Ma'am, I invite you to kindly share a few words.
Respected dignitaries on the dais, off the dais, my delegates of the conference. First of all, hats off to Oral Pathology and Oral Biology Department to bring all the stalwarts of oral pathology to this auditorium. I'm so happy to see all of you, and I am honored and privileged to stand before you as a registrar of the university to felicitate this event. I'm very happy to see that when I joined 1995, Malati ma'am was my guide or mentor or friend, or we have only one common room. We used to have lunch together, and she was my best friend during that time. Happy to see you, ma'am. And after ma'am left, Shabla ma'am joined. We all had a very good time during that time. So I'm happy to see all of you here. And different generations of oral pathology. I could see that our own student, Dr. Jayanti, she became now professor and head of the department. So happy that, so that means we are becoming old. So all of my own students are becoming HODs of different departments. So I know that definitely all of you will benefit from this array of stalwarts, and please interact with them and learn from them, and I wish all the success for this program. Thank you.
Dr. Arvind Kumar, the dynamic, charming, cheerful, and vibrant Dean of STC, as ma'am so fondly called the Rajnikant of STC, was instrumental in bringing our Department of Orthodontics as a center for M-Ortho exams, Glasgow. He has been an avid teacher and researcher. He's much loved and a hot favorite among all the students. He is almost 20 years of teaching experience, and he has numerous national and international publications to his credit, and is a much loved orator on many national and international forums. I welcome you, sir. Kindly grace us with few words.
Good morning, ladies and gentlemen, dignitaries on the stage, off the stage, and my dear students and students from various dental colleges. I welcome you all to Savitha Dental College for this awesome conference, international conference on oral pathology and oral biology. And I heard it's one of its kind which has been happening in Savitha Dental College. So conference is always a platform where we share the knowledge, and I'm really happy to see lots of stalwarts of the oral pathology department being in the same hall to share their knowledge with you people. And I think it has to be a more of interactive session for you to people to learn and take home things from this college. So I wish Department of Oral Pathology to conduct this conference in a grand way, and all success for this conference. Thank you once again.
Thank you, sir. Thank you, ma'am. Now we move on to the most awaited award ceremony of this morning. So I would like to invite our Dean Sir, Registrar Ma'am, and our most respected advisor Sir to kindly give away the awards. I will be calling the names one by one, sir, and we'll be giving the awards. So now for the most prestigious award of this conference is the Lifetime Achievement Award, and I think we don't need any guesses for this, because it goes to a very senior professor of our association, of our oral pathology fraternity, Dr. Jagdish Vishnu Tukkari sir. I request you to kindly accept our Lifetime Achievement Award. Now for the next. Moving on to the next award. Award for Senior Pathologist for Outstanding Contribution to the field of oral pathology, Dr. Ranganathan sir. Now for the next award, the award for the outstanding achievement in the field of oral pathology again, to none other than Dr. SPS, our fondly called SPS sir, Dr. Shivapada Sundaram sir. Now for the next award for administrative excellence in the field of oral pathology goes to Dr. Nadeem sir. Thank you. Now I would like to continue with the award ceremonies for the other eminent people in oral pathology. So now I would like to call upon Dr. Malati ma'am to receive the award of significant contribution to many years in the field of oral pathology. Dr. Malati Narasimhan ma'am. Now I would like to call upon Dr. Shivakumar Gopalakrishnan sir to receive the award of significant contribution in the field of oral pathology. He's our first batch of Savitha Dental College undergraduates. So the next award is to Dr. Sai Krishna sir, who is the professor and head of the Department of Tagore Dental College. Now I would like to call upon Dr. Satish Muthukumar sir, the professor and head of the Department of Chettinad Dental College, to receive the award for significant contribution to oral pathology. Sir is an eminent researcher and an effective orator. Now I would like to call upon Dr. Satish Kumar sir, head of the Department of Karpagavinayaka Dental College. Sir has always been supportive to us and is always a part of all our endeavors. Now I would like to call upon our very own Dr. Arvind Babu sir. He is the head of the Department of Balaji Dental College, and from day one sir has always been a support to us and he's always helped us in all ways possible. I have no words to explain that support he offers to us all the time. Thank you, sir. He received the award for significant contribution in the field of oral pathology. Now I would like to call upon Kavita ma'am, the professor and head of the department of Meenakshi Ammal Dental College. Ma'am also seems very quiet, but ma'am is a very effective teacher and a researcher. She has always been passionate in the field of oral pathology, and she receives the award for significant contribution in the field of oral pathology. Now I would like to call upon the teacher of teachers in the field of oral pathology. So that would be none other than our very sweet and very effective teacher, Dr. Shamala ma'am, who gets the award of Best Oral Pathology Teacher Award. It's a special award for ma'am. Moving on to the next award. Now we are going to give awards for the not so senior oral pathologists. So that first would be a professor from the Department of Oral Pathology, Dr. Sharada T. Rajan, who receives the award for Best Innovator in Oral Pathology. Ma'am has numerous grants to her credit and she's an ardent researcher. Thank you, ma'am. Next, I would like to welcome Dr. Yoita sir. He's got numerous grants to his credit and he's an ardent researcher. So he receives the Oral Pathology Researcher Award. Now I would like to call upon Dr. Chintu Kenyam Kumar. She receives the Oral Pathology Young Achiever Award. We should all encourage her. Next, I would like to call upon Dr. J. Dinesh Shankar from Vivekananda Dental College. So he receives the award of Inspiring Oral Pathologist. Please encourage him with your applause. Now I would like to call upon Dr. Priyanka Cholan. She's again the alumni of Savitha Dental College and she is may seem young but she's a professor in the Department of Periodontics from SRM Dental College and she receives the award for Best Innovator in Oral Biology. Let's applaud her. Next, moving on, I would like to call upon Dr. Lakshmi. So very happy to have her. She's also another alumni of our college. She's my senior in the undergraduate. So she receives the award for the Best Early Researcher in Oral Biology. Next, I would like to call upon Dr. Santo Grace, who also receives, okay, she's also the alumni, don't think we are biased, but She's also another alumni of Savitha Dental College, and she's right now a reader in SRM Dental College. She also receives an Early Researcher Award. Next, I would like to call upon the professor and head of the department, the teacher of many of us here, Dr. Uma Maheshwari ma'am. So she receives the award for Best Diagnostician in the field of oral biology. Ma'am is a PhD and she has numerous publications to her credit, and she's an ardent researcher and also has grants. Next, I would like to call upon expert postgraduate in oral pathology skills. Sorry. So I would like to call upon Dr. Vijay Lakshmi ma'am, who's an eminent scientist, like I told you, from the Adyar Cancer Institute. She's always been a support to us. She's collaborated numerous projects for us, and we are really happy and proud to have you here, ma'am. So ma'am receives the award for Best Collaborator for our department, Oral Pathology.
Next to receive award is Professor Dr. Rajeshri ma'am from University of Madras. She deserves a special round of applause. She's been traveling with the Department of Oral Biology for more than a decade now and has been instrumental in devising many research projects. We are honored to honor you, ma'am. Thank you, ma'am.
Next, I would like to invite Dr. Rachel to receive the award of Best Postgraduate Student in Oral Pathology from Ramchandra Dental College. Now I invite Dr. Ashwath from Sai Mukambagi Dental College to receive the award for Best PG in Oral Pathology. He's a very active oral pathologist. He always visits us for our Star Summit, and he's been a judge for many of our students. Now I would like to welcome Sarathal from Vivekananda Dental College, who receives the award for Expert Postgraduate Oral Pathology Expert Skills. Now I would like to invite Miss Divya Lakshmi from Ramchandra Dental College, who receives Best Undergraduate in the field of Oral Pathology Award. She's a final year BDS student from Ramchandra Dental College. Thank you. With this, we come to the end of the award ceremony. I would like to congratulate all the awardees, and I would like to thank the dignitaries for kindly being patient in giving away all the awards. Now I invite Dr. Ramya ma'am to kindly deliver the vote of thanks.
Before that, we would like to extend our warmest thanks to our heads. So I call Pratibha ma'am and Karthikeyan sir to felicitate I request ma'am to felicitate our visionary sir. We are very thankful, sir, for being with us. I request ma'am to felicitate our ever-smiling registrar ma'am. The small token of gratitude to our Dean sir, ever motivating Dean sir. So we request all the awardees to please come for a photo session, please. I'm humbled and honored to stand before you to deliver the vote of thanks. All of you would be thinking this is our session 1 or season 1 of Oral Pathology and Oral Biology Expert Awards. Why is this award being given? This is to shout out loud that the specialty of oral and maxillofacial pathology is such a beautiful specialty, and to tell the young minds that this specialty is so beautiful and it is the foundation of dentistry itself. Only if you master the subject of oral biology and oral pathology, you will be a successful practitioner first. So that is why we wanted to enrich the younger minds and to really showcase what we are, and never ever that we have had awards to felicitate our own specialty. It has all been very skewed, and this from now we will be really conducting this. And for season 1, I'm really humbled and honored to have a galaxy of stars amidst us. You know how big they are, and thank you so much. Thank you everyone for having agreed to be with us. Your time is priceless, and we value every second of your time for agreeing to be with us here. And we also thank our Rajshekhar sir for agreeing to be with us, our registrar ma'am and our dean sir. They have been ever motivating us, and they have been pillar of supports in all our endeavors. I thank Pratibha ma'am to have given me this opportunity to conduct this program, and she's always been a pillar of support, and just mentioning her name, everybody knows, and she represents oral pathology, one of the stalwarts of oral pathology as well. Thank Karthikeyan sir for all the support, and thank all my peer faculty, the sweat and every hard work which went behind in conducting this program. I thank all the postgraduate students and all the supportive staff of special mention, Ravi sir from Purchase Department and supervisor, and all the supportive staffs. If I've missed anyone, thank you so much, and thank you for being with us. Awardees can please come over to the stage for the photo session.
We request you to bring your certificate and shield and kindly assemble for a photograph.
Youngsters can please come in front. You can sit in front. Yeah, students can.
Request the faculty of oral pathology to please come on stage.
Ready?
Faculty of oral pathology, please.
Okay, sir.
Thank you one and all. Now I would like you all to rise for the national anthem. Following that, we have a high tea served outside.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you one and all. You can please have the high tea which is served outside. We would like to ask the guests and the VIPs to assemble in the dining hall for the high tea.
world as well. We have with us respected Shivabhadra Sundaram sir as the moderator of the session, and we have again stalwarts to talk about this topic. Both of them are eminent speakers in this area. So I request SPS sir to introduce the speakers. So our first speaker for this session would be Dr. Simranjit Singh. So Simranjit Singh completed his master's in dental surgery in oral pathology from Mahatma Gandhi Postgraduate Institute of Dental Sciences, Pondicherry. He got his postgraduate certification in forensic sciences and forensic odontology from the International Forensic Sciences Education Department of Government of India and Government of Maharashtra. And he is also pursuing his PhD in oral pathology from Savita Dental College under the guideship of Dr. Pratibha Ramani ma'am. He is currently working as a senior assistant professor, Department of Oral Pathology, Dr. Harvansh Singh Judge, Institute of Dental Sciences, Punjab University, Chandigarh. He has authored many textbooks like Dental Triplet, a complete review of NEET MDS, INICET, AIMS, PGI, SRship, government jobs, and dental entrance examination papers, and Dentacme. One of my favorite books authored by Dr. Simranjit Singh is AIMS 2012, I think. That book is still with me in my collection. It is a very interesting book. Those PG aspirants, definitely I would recommend that textbook of Dr. Simranjit Singh. And he also has numerous national and international publications in various reputed journals. I invite Dr. Simranjit Singh to address the gathering.
Good morning, everybody present. At the outset, I would like to thank the organizers of the event for making this event possible. And it is an honor for me to be speaking in front of Dr. Shivabhadra Sundaram. We have been reading his textbook right from our UG days. So I will be talking about various options which we have at our hand when we complete BDS. I'll discuss about various options which are there in India and also abroad. I'll talk about US, Canada, Australia, and New Zealand. So first we will start with abroad options. We will start with Canada. So like we have DCI here in India, similarly there is a board known as NDEB, National Dental Examining Board, which regulates dentists in dental profession in Canada. Now this is an important slide because Canada has both the options. You can go there, enroll yourself in DDS program, study and then practice. Or you clear 2 more exams and you can practice directly. That is commonly known as equivalency process or direct license process. Now before you sit for the exams, obviously you cannot practice directly, you have to clear certain examinations. Before you sit for the exam, you have to create online profile and then sit for the first exam AFK. So NDB will evaluate whether you are a genuine student or not. They will evaluate your degree, mark sheets, everything. Once that is done, you can sit for the first step. First step is common, that is assessment of fundamental knowledge, AFK. After AFK, you can go for either of the processes. You can go for DDS and practice, or you can clear 2 more exams, that is ACJ and NDECC. What are these exams we will talk about? So anybody knows what is the fee structure of DDS? How much you will have to spend if you are going for DDS is just a graduation, right? So what amount of fees you have to spend in that? How many of you are interns here? So how much fees you will spend? It will be around 1 to 2 crore Indian rupees if you are looking for DDS option. But once you are DDS, you can practice essentially all over the globe. You can practice in US, you can practice in Canada, Australia, New Zealand. But we always say that admission into DDS is of prime importance. Fees is managed because you get loans, loan can be easily paid back, you get long time to pay it back, and the interest rate is very low. So anyways, in DDS you will be spending time as well as money, 2 to 3 years, and if you do not want to do that, you can go for the second pathway, but 2 more exams are there, and the fees will directly come down from 2 crore rupees to the examinations will cost you around 5 to 6 lakh rupees, right? And also the time involved will be less. Instead of 3 years, you will be spending around 1.5 year in the process of equivalency, right? So whether you come through DDS pathway or you come through this pathway, there is another exam at the end, virtual-OSCE. The success rate in virtual-OSCE is to the tune of 98%. So it's just a formality. So this is the list of dental schools which is there in Canada. There are 10 dental schools. In entire Canada, you have only 10 dental schools. So if you're looking for DDS, you have to get admission in one of them. But if I compare that with US, if you're looking for DDS, then US is a better option because it has 70 dental schools, around 70 dental schools, 7 times more the number of schools, more the number of seats, more the chances of getting admission into DDS. But US does not have direct license pathway. Only DDS option is there. Canada has both. So if we talk about the exams, assessment of fundamental knowledge, AFK, it is the first step, whether you want to go for DDS, whether you want to go for direct license, AFK is the first step. It has 200 MCQs to be done in 4 hours, 30 minutes, computer based and booklet format. Passing standard is 75 percentile. So if you pass the exam, you won't get the marks breakup. You will just get a pass. If you fail the exam, they will give you the exact percentile which you have scored. So that is why your CV becomes very important. When we talk about these countries, when we talk about US or Canada, CV is important. Like you're attending this conference. It is international also. Its fees is also very reasonable. So it is a very big boon. I give example of this conference at various places. So what I'm trying to say is try to attend events, try to present something in it. Paper is better than poster. Publications are important. Try to involve yourself with postgraduates and faculty members. If research is not possible, then at least review articles. So 3 to 4 publications in good index journals that would add on to your CV. Apart from that, charitable work, association with NGOs, all these things, they will count if you are looking to pursue any kind of program internationally. So number of attempts are 3. You have examination centers in US and Canada. The validity is 2 to 5 years. So within 5 years of clearing this exam, you have to clear all the 3 steps. So this is the blueprint that which subjects you need to focus more on when we prepare for international exams. When I talk about Indian exams, all 19 subjects are important. But when we talk about international exams, all your final year subjects, oral pathology from third year, dental materials and pharmacology from second year, and applied anatomy and physio from first year. I'm sharing facts with you. I'm not against any subject, but these are the subjects from which questions will be asked. This applies to all US, Canada, Australia, New Zealand, everywhere. Now, if you're going for DDS, then ACJ is not required. You clear AFK, first step assessment of fundamental knowledge. You apply with your CV and pass of AFK to various dental schools. If they find you are good enough to be called for interview, they will call you for interview. There will be an interview. Along with that, there will be a clinical test. So if you clear that, you get admission into DDS and you can practice. But if you want to save your time and money, as I discussed earlier, then you can go for this pathway. If 100 students are preparing for Canada, 90 will prepare for direct license. Only 10 will prepare for DDS. So this has more fan following because it saves your, essentially it straight away saves your 2 crore rupees. It is just 6-7 lakh rupees. Now ACJ, again, it is computer based format. You have 120 to 150 MCQs. More than one answer can be correct, to be done in 5.5 hours. Again, 75 percentile is pass. Examination centers are in US and Canada, 3 attempts. And within 5 years of clearing ACJ, you have to clear practical exam. Till now we are talking about MCQ exams. Again, your perio, oral medicine, radiology, oral pathology, that is the most important subjects for clinical judgment. The name itself is clinical judgment, right? So from the name you can make out which subjects will be important. So treatment planning is important in this. Now coming to the third step, NDECC. This is the most important step, National Dental Exam of Clinical Competence. It is conducted over 2 days. So in one day, you will be doing 7 clinical exercises, and in one day, there will be 10 situational judgment stations. Now, what are the clinical exercises? And you have to perform them on what all teeth? There will be no patients, obviously. It is all on mannequins. You do, in Canada, they use Kilgore jaws. Kilgore typos, they are used in Canada. In Australia, they use Columbia. So these are the 2 major typos which are used. Kilgore in US, Canada, and Columbia in Australia. So what are the clinical exercises? Number 1 is crown preparation, anterior, posterior, anything you can get premolar also. Second exercise is provisional crown, fabrication on the crown which you have prepared in the exam. Third exercise is endo-assess opening. There are special teeth of Kilgore in which you can see the root canals. You have to do assess opening only in that. Number 4 is class 2 amalgam prep. So MOD usually. Number 5 is class 2 amalgam restoration. Usually complex restoration will be there. Number 6 is class 2 composite restoration. And number 7, class 4 composite restoration. So these 7 exercises you have to perform in single day. And on the second day, you have situational judgment. It is like Viva, like you have been giving right throughout your graduation. There will be examiner, a screen will be there, and you will be there. You will be given a clinical situation, your communication skills, your ability to diagnose, your ability to explain the diagnosis and treatment plan to the patient, that will be assessed. So you have only one examination center, that is in Ontario, and unlimited attempts. But obviously, maximum 2 attempts you will give because it is expensive exam. It is $8,000. You won't keep on attempting it again and again. There is no expiry. Once you clear it, you have the license to practice. Through this license, you can practice in Canada and New Zealand as well. So New Zealand also accepts the Canadian license. This is the location of the center. This is the center from inside. You have half chair dental setup. I'll show you the close-up picture. On the left side, you see the picture from NDECC center. It is a half chair dental setup. The head which you are seeing, it is known as Darwin head. And you can see the skin around it, and inside you have the Kilgore jaws. The same setup we have here in India in Chandigarh. This right side picture is of our classroom center in Chandigarh. You have the same Darwin head, the skin, the Kilgore jaws, and obviously you can clear these exams if you practice on actual teeth which are going to come in the exam, right? So it is quite obvious you have to practice on Kilgore jaws in the same simulated environment in order to clear the exam. So what is the financial burden involved in direct license? In DDS, I told you 1 to 2 crore rupees. In direct license, it will be very less, around 6 lakh rupees. Now, once you start earning, till now we have been talking about that what you will be spending. You should also know once you start earning, what is the initial basic starting package which you get as an associate dentist? Anybody knows or any guesses? It will be around 1.5 lakh dollars per annum. This is minimum basic starting, and it can go up to 3 lakhs, 4 lakh dollars also per annum. If I break down it in Indian rupees, around 7 to 8 lakh rupees per month. It can go up to 25, 30 lakhs, 35 lakhs per month also. Now this is a very encouraging slide. How many students appear? What is the passing percentage? This also we should know. So before that, how many students appear for NEET every year? NEET PG. Is it in lakhs or thousands? Thousands. Around 24,000. And if you want a government seat or a good private college, what should be your rank? Yes, government seat up to 350 rank. I'm talking about all India quota, not state quota. Good private college, 1,000, 1,500, 2,000, 2,500. So success rate varies. For government seat, it is 1 to 2%. And for good private seat, good branch of your choice, it goes maximum up to 10%, right? And students are in thousands. If that is achievable, people achieve that, right? So this is very much achievable. If I talk about 2023, if you see, AFK is 926 students they appeared. Out of that, passing percentage I'll talk 60%. Second step, it is 77%. This is latest 2023. It is from NDEB official website, right? And third step, it does come down. First and second step are MCQ exams. Third is clinical exam. But it comes down to around 20 to 25%, which is also very high, right? 60% is too high. So definitely you'll clear the exam provided you have prepared properly. So that was in brief about Canada. Now we'll talk about the other country, INBD. INBD exam is for which country? Anybody knows? INBD exam is for which country? Integrated National Board Dental Examination, US. So US does not have the option of direct license. You have to go there, you have to study, then only you can practice. You have to do DDS. This is the list of the steps. You will generate a dent pin, your EC evaluation will be done, and then you can book the date for the exam. Write INBD, get a pass in INBD, applied through CAPIT. CAPIT is application process, centralized application process for international dentists. Apply to dental schools. There are 70 dental schools. On an average, a student will choose 8 to 10 dental schools and apply in them. Again, INBD, you will just get a pass. So your CV, as I told in the beginning, is very important, especially in US. So if they invite you for interview, there will be an interview and a bench test. You clear that and you do DDS. Bench test is basically clinical test, same exercises as I mentioned earlier. Now what is INBD? It is 500 MCQ exam to be done in 1.5 days, computer-based format, and passing percentile is 75. Examination centers are in US and Canada. This is the only exam which you can attempt within your internship. Rest of the exams which we will talk about, you can attempt after your internship gets over. This exam you can attempt within your internship. So 300 questions will be routine MCQs. 200 questions will be like this. You get a clinical or a maybe radiographic picture, histopathological picture, and a brief history is given, and they ask you maybe 5, maybe 6 questions around that. So if I talk about this particular question, what will be the answer? It is a fungal infection, right? So then they will ask you what is the treatment for this. Associated with this topic, they will ask you maybe 5, maybe 6 questions. And what is the fees? It is very reasonable, $845 plus $350 for international students, and it is around 1 lakh rupees, and quite reasonable fees for an international exam. Then if you apply through CAPIT to schools, there will be a bench test and interview. This is one of our students had shared this picture recently. University of California bench test setup. Again, it is a half chair dental setup with the mannequin, and most of the universities they are also using Kilgore jaws. So that was briefly about US. The only option that exists in US is DDS. And if we talk about Australia, in Australia there is no option of DDS. The only option that exists is direct license. So Canada has both the options, direct license as well as DDS. US has only DDS option, and Australia has only the option of direct license. So it is very straightforward. ADC Australia, you would have to do initial assessment, then a written exam is there, and then a practical exam is there. Initial assessment, all those degree assessment, everything will be there. Around 30,000 will be the fees. Written examination twice in a year, March and September. Fees is 2,000 Australian dollars, around 1 lakh rupees. And this is the only exam for which you have center here in India, written exam. You have center here in Chennai as well. Practical is in Melbourne. Written exam you can clear from here. So it is an advantage. It is offered in computer-based format. As I told, centers are all over the world. Nearest is Chennai. 280 questions will be there in total to be done in 2 days. All will be clinical scenario-based questions. You will get around 56 case scenarios, 54 or 56 case scenarios. Each scenario will have 5 questions associated with it. So total 280 questions divided in 4 sessions, each session having 70 questions. Again, all those subjects which I told in the beginning, final year, OP from 3rd year, DM Pharma from 2nd year, Applied Anatomy and Physio from 1st year. They are the subjects which you have to study for these exams. And passing grade is A and B. If you get a C, you fail the exam. You have to attempt the entire exam again. So minimum grade B you need. Written, anyhow you will clear. MCQ based exam. Definitely if you sit down, you know what to study, what not to study, and you prepare properly for maybe 8 months, 9 months, you will clear the exam. Important are practical exams, right? You need to practice on the same stuff which is going to come in the exam. Lists are there on their website. You go to NDB website, go to Australia website, there are handbooks given, everything is given, what all typos they will be using, what all instruments they will be using. They have given each and everything. Obviously, you have to train for it with those things. So practical is conducted essentially throughout the year. Cost is 4,635 Australian dollars, around 2.5 lakh Indian rupees. And this is the center, Melbourne center of ADC. Again, a 2-day examination. 1 day you will be doing those 7 or 8 exercises which I told you in the beginning, crown preps, restorations, and cavity cuttings. Apart from that, there will be OSCE. Second day will be OSCE, objective structured clinical exam. 10 OSCEs will be there. They may ask you to do CPR. They may ask you to go for an X-ray or maybe extraction of the tooth. Obviously, you won't extract the tooth. You will demonstrate the entire procedure from extraction, starting from landmarks, LA, and then post-extraction instructions also, what all instruments. So entire exercise you have to do. And then you have a communication OSCE also, in which they will assess your communication skills, diagnosis and management skills over a period of 1 day. So that was all about Australia. Coming to New Zealand, New Zealand does not have its own examination. It depends on other countries. Either you should be a DDS degree holder, or you should have AFK, ACJ, and DECC cleared from Canada. Canadian license should be there. or you should have Australian license, written and practical of Australia you must have cleared if you want to practice in New Zealand. So we have at Dentecme, we are running academy from last 10 years. We have all the courses which I mentioned, theory as well as practical for US, Canada, Australia. INBD, AFK, ADC written, USA bench test, NDCC Canada, ADC Australia practical exam. These are some of the pictures from the center where we train the students for practical. Theory is online as well. So there are one-to-one demos, the same instruments which you will be using in the exam, the same instruments you get at our center. I'll share some of the results. We have limited time on our hands. So I'll just be running through the selections. This is recent most in ADC Australia, then AFK, Kiran Preet again in AFK. Long list of selections in INBD. She is Dr. Kaval Preet. She is 46, 47 years of age. She is MDS in PEDO. And see, getting a call from single university for interview is difficult. She got calls from 4 universities, right, for interview. Though she has a good, strong CV and a long teaching experience that helps in the entire process. She's MDS in PEDO. And she prepared for, she wrote INBD in May 23, last year. And then she was waiting for interview call. Once she got the call for interview, she barely had around 20-25 days to prepare for the bench test. Now, this is a common mistake students do. You should always prepare for, once you have cleared INBD, you should always prepare yourself for the practical test well in advance. And then once your date comes, your interview date comes, then you can just practice. You can do home setup. Home setup is very cheap. So anyhow, she came especially from US to our center in Chandigarh. We trained her in 12 days. It was a task, very tedious task, but anyhow, we managed to do that. She cleared the exam, University of Louisville, and she got into this interview invite from 4 universities and accepted for DDS in 2 universities. Oh, it is a very rare finding which you say. In Louisville and in Rutgers. She is joining DDS in Rutgers this month. She is Sukriti. She also came from US for the bench test training. And Muskan and Shreya, they appeared for University of South California bench test interview last month. Some of the INBD selections, I'll run through them. If anything special is there, I'll talk about it. So AFK Canada, then INBD is conducted throughout the year, every month. So you'll have selections every month. Then Manvinder and Swati. Swati is also joining in Boston. Boston is a university which does not have bench test. So many students look for it. They do not have to go through the clinical exam. But again, very tough to get into this university. Then some of the AFK, INBD, Australia selections, INBD selections, ADC Australia. Earlier INBD was part 1, part 2. So those selections. So with this, we come to the end of abroad part. Right? Abroad, I've talked about Canada, US, Australia, and New Zealand. Now we talk about career options in India after BDS. So which is the major exam in India if you want to pursue MDS? NEET, right? After NEET you have AIMS, PGI and JIPMER combined in the form of INICT. Apart from MDS, what other options you see in dentistry? What other exams are there in dentistry apart from NEET, MDS and apart from INICT? Anything that comes to your mind? Junior residency, have you heard about JRship? Junior residency is there. Through NEET, we can go into a very prestigious organization. What is that? Through NEET, apart from MDS, what else you can achieve? Up to 1000 rank if you have, you can apply Army Dental Corps, and then you have government jobs as well. So these are the various options. I'll talk briefly. And this is the most important slide of today's session. Whatever you are going to do is going to come through preparation, right? Whether you're going to open clinic directly, you're not going to go abroad or not going to pursue MDS, though it is not recommended. You should always do post-graduation. Preparation you have to do, right? You, at least this should be takeaway from today's session. You decide something. the students, they should decide something. Whatever you have decided, give at least 1 year to it. It should not be that you keep on constantly changing your decision. Take time for making a decision, but once you have made the decision, stick to it. Give a religious effort. So as you told me, you have NEET, MDS, Army Dental Corps, INICT, JRship exams in various institutions, then government job exams. So all these are opportunities basically, not exams. We call them opportunities. So NEET, MDS. What is the rank required for getting government seat? As we discussed, it is up to 350 rank through All India quota. Number of students appeared approximately 24,000. This is last year NEET stats. Number of students qualified 12,000. So how many questions come in NEET? Anybody knows how many questions come in NEET? 220, 240, 260, 280. Difficult question. 240 questions they come in NEET, right? So out of 240, if you have to qualify the exam, you need to get only 60 correct. Just see the leverage. 240 and 60 means you have the leverage of 180 questions. If you go in the exam, sit in the exam, believe me, you just close your eyes and mark all the options, C options as correct. You will get 60 questions correct, right? But I'm not recommending you to do that. It is not at all recommended. If you study properly for maybe 6 months, 5 months, you can qualify the exam. Because qualifying, this was the which came earlier, 272 marks out of 960. Then it was further reduced. I'm not sharing that reduced percentile with you. So what is NEET exam pattern? Conducting bodies NBE, 240 questions, Part A and Part B. This is important. Part B is third and final year subjects. Part A is first and second year subjects. So which you think is more important, Part A or Part B to clear the exam? Part B or A? Part B, if you do not know, you do not have the right to sit for the exam, right? Part B is clinical. As a dental surgeon, clinical everybody will know. Part B will keep you in competition. Part A will give you a 2-digit rank, right? Pharmacology, myself, I was not able to remember even in second year. How will you remember it in internship without revision? Revision is important. Studying these subjects properly, it is important. Part A will give you the rank, right? So single day, single session CBT, negative marking is there. So negative marking is good or bad? It is very bad, not only bad. It is very bad for those who are doing guesswork, right? And it is good for them who are actually preparing and sitting for the exam, right? And also, out of 240 questions, what do you think, how many questions you should attempt? 240 questions. What number is a good attempt? 180, 200, 220, 230. 220 or 230? See, what I feel is if exam is easy, if you are prepared, you go for the sit for the exam, you will come to know whether it is easy or difficult. So 230 is a good attempt. Right? 230 is a good attempt. If it is difficult, then 220 is a good attempt. But nothing less than 220. Rank will not come. This is what we have experienced. There may be variation in that. Opinions may differ. But what we feel, we usually recommend students who are preparing for the exam 220 to 230 because you can do your calculations. Suppose you have over attempted 40 questions. You knew 190 questions. You have over attempted 40 questions. Out of those 40 questions, 30 are wrong. 30 you marked as wrong, 10 are correct. So you land on the negative side or positive side. Still you will land on positive side only. And obviously luck is required. If you are marking all 40 wrong, that means some problem is there with the luck factor also. Right? Along with the hard work, luck is also important. So negative marking 1/4 means nothing, 0.25, minus 0.25. If you have eliminated 2 options, only 2 options you are confused, that is a must attempt question. You have to attempt it if you want to get rank. So Army Dental Corps, every year Army checks out vacancies. Recent most was you could apply till 17th December if you had appeared for NEET last year. And rank required to be shortlisted for ADC is up to 1000 rank. You get commissioned as captain. SSC is there for up to extendable up to 14 years. Permanent commission you can go in for after 2 years of service. And through army, once you are commissioned, you can do MDS through AFMC and RR. Again, you have to write NEET. Your merit list will be created. Salary is 1 plus. If you leave army, you get ex-serviceman quota. Even if you leave after 5 years of service, you get ex-serviceman quota. Any government job exam, dental or not dental, in India will have ex-serviceman quota. Plus, if you leave after 5 years, you will have around 45 to 50 lakhs rupees as saving. You can start your clinic, good clinic. So INICT MDS conducting body is AIMS, 200 questions, part A, B, C, D, does not matter. Single day, single session, computer-based test. Negative marking is 1/3. But still you are going to attempt 180 questions out of 200 if you want a rank in AIMS. You will have different types of questions. Junior residency, it is 1 year, 6 months to 1 year job kind of thing. And in prestigious institutions, PGI, GMCH in Chandigarh, Maulana Azad, Ram Manohar Lohia, Lady Hardinge, Jipmer in Pondicherry. So around 9-10 institutes are there. Again, preparation has to be all India level. So government jobs. How many of you who are students here want a government job? Okay, 1, 2, 3, so 4. So rest of you, if Tamil Nadu government comes and gives you offer letter for joining government job, you won't join. Right? So government jobs do come. Again, preparation has to be all India level. If you prepare for NEET, essentially you're preparing for all types of competitions which are conducted in India. So start how you will have seniors who can guide you. You can go to Google. Google will guide and confuse you. So Dentech mein, basically we are 3 persons. All of us have done through All India. I have done from Pondicherry, MGPG. I had All India 86 rank in 2010. And 2 other persons are also from GDC Ahmedabad. We all 3 are oral pathologists. Right? So we have been authoring books from last 10 years. The recent most is Dental Triplet. It is available on Amazon and Flipkart, and it is the only book right now which has recent 7-year papers of NEET, AIMS, PGI, government jobs with explanations. Right? It is basically a revised version of AIMS 25. AIMS 25 doesn't come now. It has been replaced with Dental Triplet. Right? So rest of the things, study material and all, it will be provided. So this is the cover page of the book. It comes in 2 volumes, and around 2200 pages are there. Right? You can search on Google, it will be there. And we released the second edition. First edition came in 21, second edition in September 23. Within 15 days of releasing the book, it was #1 bestseller in dental exams category on Amazon. This is a screenshot from Amazon app, right? So it is a must-read book, those who are preparing for Indian entrance examination. So you have courses online as well as foundation courses for your juniors who are still in BDS first, second, third year. I'll show you pictures of our classroom center, which is there in Chandigarh. And whichever academy you join, always attend a demo first. Demo class should be attended, and then you should join the academy. So some of the ranks I'll just quickly run through. I have limited time, right? So INICT, Mehak has recently joined Perio in AIMS Bathinda, and Hina has joined in AIMS New Delhi Ortho Oral Surgery. I do not remember exactly. Odisha, GMCH, All India rank 1 on all junior residency exams. INICT made 23 ranks. In Punjab, from last 5 years, we have first rank, right? So all these are those. Jammu, Ankita, first rank, then Wani, like that. I'll just mention about him and I'll finish. He is Faizan. During graduation, he did not have any interest in dentistry. He did not buy even a single book, unfortunately. That is very unfortunate. Uh, do you know about those books, Master in Dentistry? Some books come that 10 years. Yeah, first BTS, second. It is obviously, I request all of you that do not read those books. They are detrimental for the education system. If you do not frame a proper, if you do not have the basic knowledge, then how will you treat the patients, right? And definitely by reading those books, you cannot get any kind of rank anywhere, be it India or abroad. You have to read standard good textbooks if you want your basics to be clear. So anyhow, coming back to him, he did not even buy those books. He borrowed it from seniors, read it, and then he passed the graduation. So I'm not saying that you should do what he has done, but just as a part of story, I'm telling you. So he went back, he looked for various options apart from dentistry, but nothing clicked. So he came back to dentistry. Then he gave serious effort for around 1 year, 10 to 12 months, 12 to 14 hours in a day, and he got All India 315 rank. If he can do, I know him personally, zero knowledge of dentistry before preparation, before starting preparation. And if he can do it, definitely all of us can do, you can do it, right? He had third or fourth rank in JNK. Now he is doing oral surgery in GDC Srinagar. Right? So these are some of the Haryana results, then PPSC results. And we are there all over the social media, YouTube, anywhere, Instagram, everywhere, Dentecme, you will be able to find. And I thank you so much for listening patiently. All of you are wonderful. Thank you. Right.
A good lecture by Simranjit Singh.
Thank you, sir.
Any clarification needed from the audience?
Our next speaker for the session for career enhancement is Dr. Jayanti Varun. She is a professor at the Department of Oral Pathology and in Assisia College of Dental Sciences and Research, Kerala. She is a gold medalist during her undergraduation from Savita Dental College. It's such a proud moment to us. And from there, she pursued her oral pathology from MGR Medical University. And during her post-graduation, she was a very successful student, and she has had various high-ending ranks, and she was a medalist as well. She is a fellow of the Indian Association of Oral and Maxillofacial Pathologists and is recognized PhD guide in the Kerala University of Health Sciences. She has completed her research methodology courses from Manipal University and Kerala University of Health Sciences. She has conducted research methodology workshops in various dental colleges in Kerala and Tamil Nadu. She is associate editor of Journal of Oral and Maxillofacial Pathology, Journal of Indian Dental Association, and Kerala Dental Journal. She is a reviewer in high-impact journals like Archives of Oral Biology and Journal of Oral Pathology and Medicine. She has numerous publications in national and international journals. It's a very proud moment to have you here, Jayanti. And in spite of the flood and everything, we really thank Simranjit sir and Jayanti ma'am for being with us again, and looking forward to listen to you, Jayanti. Please come.
Yeah, it's almost good afternoon now. So I will not take much of your time. I know you all must be exhausted after that long inauguration and the talks. So I'll quickly go through. I'm not here to give any lecture. I'm just going to have a very brief and short discussion with all of you. Before that, before we move on to what I'm going to talk about, can I know just briefly, are you undergraduate or postgraduate students? This side, most of you. undergraduate students, can you please raise up your hands, undergraduates? So most of you are undergraduates, because my talk here is focused mainly for undergraduates. Most of what I wanted to share is already told by Dr. Singh, but I would like to tell from my perspective few tips and tricks of how to crack exams. Now, this tips and tricks, though it is focused mainly for the NEET MDS exams, you can also take it for any competitive exams for that matter, for the government exams or for the junior residency exams. The principles and guidelines would be the same. Now, so many years back, like maybe even 7 or 8 years back, only BDS was enough. Yes, most of them, I know many of my seniors and friends from Savita Dental College who are successful practitioners who have a roaring practice with BDS. So those days, MDS was not mandatory. Only people who were interested to pursue higher went for MDS. All the others were very happy with BDS and they had very good practice. But now the situation is not the same. Things have changed a lot, like MBBS. Even in BDS, there is a lot of competition. So to survive in this field of competitive world, we have to go for MDS, which has become really mandatory. So when we talk about MDS, and I'm telling you, I'm here to give you some tips and tricks. So you all must be wondering, when Dr. Ramya gave the introduction, she's a professor in oral pathology somewhere from Kerala. Why she has come all the way here, and why is she giving us tips and tricks? Why am I be called here to give you this lecture is because over the past 13 years, I have trained more than 2,500 MDS aspirants, both in Tamil Nadu and in Kerala. There were 3 famous dental coaching institutes 10 years, 15 years back. Speed, I don't know if you have heard about it. Now, of course, centers like CDs have become very famous. But before that, we used to have Speed, Target, and Dental Pulse Academy were very famous for coaching MDS aspirants. And all these 3 centers in Bangalore, Chennai, as well as in Kochi and Trivandrum, I used to take classes for students. And I am very, very proud to say that from all these institutes, many of my students, at least out of this 2,500, at least 500 or 600 of them have already successfully completed their MDS exams. Though I am an oral pathologist, of course my expertise was in oral pathology, histology and embryology. But later when I started teaching, I used to teach only these 3 subjects. Then what happened? Those days, the MDS aspirants used to have classes along with MBBS students for the basic sciences like general pathology, microbiology, anatomy, physiology. They used to sit along with MBBS students and attend the classes. And then most of them came back. We used to get their feedback. Most of them came back and told, ma'am, they are teaching very exhaustively. Most of what they are teaching, we have not even heard about those things in our BDS. It is very difficult for us to sit with them and listen to the class. Then we separated the MBBS and BDS students. And we wanted to focus only our syllabus, because though general pathology as a subject is there, our syllabus is very limited. What we have been taught in BDS, in general pathology or microbiology or any other basic science department, our syllabus was limited. And the questions that are asked in the exams are also limited. So we started taking separate classes for BDS students, and that is how I ended up taking even microbiology and general pathology also for these students. So like before 2013, you know, I think you all are young graduates. Only for your information, we used to have different types of exams. For AIMS, we have All India Institute of Medical Sciences, we had a separate entrance exam. Then All India exam was a separate exam, that is AIPGE. Then Manipal University had a separate exam. Karnataka used to have a separate exam. And of course, the state governments had a separate state entrance. But now everything is changed, and from 2013, we have only one exam to get MDS seat, that is your NEET MDS. All the details about NEET is there on the website. I don't have to tell anything. Only the important ones I'll briefly update. We know that you all would have cleared your NEET exam only and joined BDS, so you must be knowing about it. It's conducted by the NBE, that is National Board of Education, and the role of NBE is they only conduct the NEET exam, they declare the results, they give a rank list, and they will produce that rank list to the separate state governments. They don't have any role in allotment of seats or counseling. The seat counseling and allotment of seats is actually done by the state government. So you have to apply to the respective, if you are in Tamil Nadu or if you are in Kerala or any other state, you have to apply there and then you have to attend the counseling and seat allotment will be given. So what is the basic eligibility criteria for anyone who can appear for this NEET MDS? Of course, you have to be a BDS graduate from a DCI recognized college, any college that is recognized by DCI in India, and you should have obtained a provisional or permanent registration from the Dental Council of India. This is very, very important. So, and the important point which I mentioned last, you should complete your internship before March 31st of every year. That may slightly change, but still, this is very important. If interns are here, don't get any extensions. If you get extensions and you are not able to finish your internship on time, then you cannot immediately apply for your NEET MDS exam. So keep that in mind whenever you're doing your internship. So Dr. Singh is already mentioned. This is a statistics which tells you that in India we have totally around 6,200 odd MDS seats, out of which around 1,300 will go in All India quota. And in Tamil Nadu, we have around 164 MDS seats, out of which 31 are from government colleges and the remaining 133 is in private colleges. And we all know NEET is a computer-based exam. We have totally 240 questions. Each correct answer will give you 4 marks and each wrong answer will give you -1 mark. So the total marks that will be awarded for the total 240 questions will be 960 marks. So this is in 2023, the exam was conducted and this is the cutoff score. I have specifically given the revised score because I have to be really frank here. Now, the dentistry or even the medical profession is taking a U-turn and going to a different level, where many of them, after joining their BDS course, started rethinking, have I made the right decision? Because when you look around, there are many people who have less job opportunities. You have more number of graduates passing out every year. So you are in a dilemma, will I be able to survive in this competitive world after finishing my BDS or MDS? But believe me, you have taken the right decision by joining BDS. In whatever course you have joined, you have to be smart and be one of the toppers. Only then you can survive. Be it a BDS, be it MBBS, be BTech, whatever it is, any course, you have to be good and smart enough and work hard for it. Only then you can survive. It is not that BDS is not having job opportunities. We have seen so many career options Dr. Singh has mentioned. Everything is there in front of you. Only thing is you have to be smart enough to grab that right opportunity at the right time and move forward. So don't have any second thoughts and don't be upset about anything. You are in the right track only. So the revised score is specifically given here because there were no takers. It was there in the Hindu newspaper. There were a lot of MDS seats vacant in many of the private colleges across India. There were no takers. So you must be thinking, just like that, if I write and put option C for all the answers and get some score also, even then I will be eligible for some course anywhere in any college in India. But that's not the point. You all are studying in a prestigious institution like Savita Dental College, where the standard of education is higher and higher. If you want to go to any other dental college where you need to get a good training, I told you, you need to be smart enough. You need to be very, very good and be in the front foot. For that, you need to get a good college. You need to get the course or the seat which you want. Then your rank should be really good. So if you want any seat in any college, only an MDS, then you will be somewhere in some remote places where not even one single patient will come there. You have to go sit there. At the end of 3 years, you will be awarded MDS and you can come back. There is no use for that. If you want to make complete use of your MDS, then you have to be in the top institutions where you have good patient flow, where you have excellent faculty, excellent infrastructure. Then you should really crack this exam and get a good rank. Otherwise, all this will not be possible at all. Now, this is the subject-wide distribution of questions. So we have totally 240 questions. Now, if you can see this table here, all the subjects carry equal marks. Can you see that? Right from first year anatomy till public health dentistry, everything carries equal marks. Only small change is that oral pathology and oral medicine is having 1 mark more. Others are having only 14 marks, whereas oral pathology and oral medicine has only 15. So now before we move on to how to prepare for this exam, I'm going to give you a short or brief explanation as to why pathology is important. Now for that I have to tell my story. When I joined BDS, I didn't know that there is a lot of skill that needs to be practiced and done in dentistry. I thought it is something like medicine and I joined. Then I had to do cubes, I had to mix plaster of Paris. I was totally upset. I never thought I will survive 3rd year or final year. But fortunately, I had very motivating friends. I had very good staff members. My teachers, they all motivated me. And I graduated BDS from Savita Dental College with very good marks and rank. After that, I was thinking whether I should go back and do MBA or some other course which I like. And then my good friend, Dr. Kritika Datta, she said she wants to pursue MDS. She doesn't have any company for her to sit and study. So please come with me and read. We both will study together. So we both went to her house. I stayed with her in her house for 1 month. And for 1 month, we thoroughly prepared everything. And we went and gave the exam. And I still remember when the results were announced, she got 24th rank and I got 45th rank. So she wanted only endo. She was very, very particular. She wanted only endodontics. So she got the seat, she joined endodontics. Even now, I don't know what I want. I went with her, I wrote the exam, I got the rank, but I'm telling you frankly, I didn't know what I want. And then I sat and I just thought about it. That is when pathology came to my mind. Because every time I wanted to be a doctor, I wanted to do diagnosis, I wanted to learn about the treatment. Something which was very, very close to medicine was pathology. So I thought this would be the ideal thing, and now I feel I've taken the best decision of my life because I loved for 45th rank in the same Savita Dental College, I was getting prosthodontics and periodontics department. But I didn't wanted it, so I didn't take it. I opted for oral pathology and I joined oral pathology at Ragas Dental College. And I'm telling you frankly, I have not regretted 1 minute in my life why I have taken this subject. In fact, my love for the subject started growing exponentially the moment I entered Ragas Dental College. All the staff members there, my teachers, Dr. Ranganathan, Dr. Saraswati, they all inspired me so much that pathology became a part of me. That is what I would like to tell. So I'm so happy that I read pathology and I'm a pathologist. I'm so proud to say I'm a pathologist now. And I just wanted to bring that same thought to many of you also, because many of them think that pathology is just about sitting and seeing the slides. That is what is notion that is created in many young people's mind. Even many of the BDS students do not know the importance of pathology. But just read this, you will understand that without pathology, medicine is just a guess. Yes, based on all the clinical findings, whatever you're telling, whatever you're diagnosing, it is all just a guess without pathology. I'll just give you a simple example. A patient is coming to you. He's telling that he's having a very persistent cough for more than 3 months. Sometimes when he coughs, he gets sputum tinged with blood. He's also having weight loss. He's also having fever. Now we all have read theory. Yes? Every one of us know that all these signs and symptoms are narrowing down to what diagnosis? Most probably pulmonary tuberculosis. Yes, we all know that. An experienced physician knows that the patient is having pulmonary tuberculosis, correct? So, can the physician write anti-tuberculous therapy, give it to the patient and ask the patient from tomorrow morning, take this? Can he do that? Can he do that? Why not? It's the correct diagnosis, right? The physician has made the correct diagnosis. There is no need for any laboratory test. There is no need for anything. The best diagnosis has been done with all the clinic. Why can't that be done? Because legally, ethically, it is not the right thing to do. Yes, you need to do some laboratory investigations, confirm that it is pulmonary tuberculosis, and only then you are entitled to give the treatment to the patient. So the treatment or management of the patient lies in the diagnosis. Without I'm talking about laboratory diagnosis. Without laboratory diagnosis, medicine is just a guess. So we also would like to say, I know that it is a connecting bridge. Pathology is a connecting bridge between basic science and clinical science. Now, if you see this picture here, all the basic science like anatomy, physiology, biology, immunology, everything are called basic science because they are the basics. They are the foundation. My son when he was 6 years old, he used to come and ask me. That's when maths was taught to him in school, first grade. And the first thing he learned was 2 into 2 tables. So every time 2 2s are 4, 2 3s are 6, keep scribbling. Amma, why they are asking us to mug these tables? Have you ever wondered why we are all asked to mug these tables in our mathematics? Because that is the logic. When you are trained and it is fixed in your mind that 2 into 2 is 4, it cannot be any other number. You know that right now. Whether I wake you from the sleep or now, everyone will tell that 2 into 2 is 4. Because that is the logic of this basic science. If that basics is not correct, if that foundation is not correct, then the building cannot be built over it. That is why in LKG they teach you ABCD. Otherwise, why they have to teach ABCD? You can directly go to LKG and start learning APPLE, apple. Why they have to teach you A, B, C, D, E, F? Because only when you know letters, you can frame words. Only when you know words, you can frame a sentence. So that is the importance of basic subjects like anatomy, physiology. But unfortunately, what happens with BDS graduates is, it is all fixed in your mind that you are all dental surgeons. Appa prosto, perio, ortho, these are only important to us. That is what we are going to practice, right? Why we need to know about anatomy, physiology, and biochemistry? But without that ABCD, you cannot form a sentence later. All that will become meaningless without this basics. So if you are an undergraduate who are still in your first, second, or third years, do not underestimate the importance of these basic subjects. Learn them very well. If you have a good foundation, that will be really useful for you in later stage. Now, pathology is like a branch. It's a strong branch that is connecting all these basic sciences with the clinical departments. So if you need to understand clinics, that track or the bridge to the clinical department is through pathology. So it not only tells you, pathology is not only about the study of the cause, etiology, or how the disease occurs. When you know how the disease occurs, it will also tell you the course of the disease, the complications, the prognosis, and finally it will help in the management or treatment of the disease. Now I will tell this with a simple example. There are 2 epithelial cells. The 2 adjacent epithelial cells are connected by cell-to-cell junctions. These cell-to-cell junctions are called desmosomes. Now the basal layer of the epithelium is connected to the basement membrane by another type of cell junction called hemidesmosome. This is the basic topic which all of you would have learned in your oral biology or in your oral pathology. Now what happens is, there is a group of diseases called autoimmune diseases. The concept of autoimmune disease is that our immune system is attacking our own cells and tissues. That is what autoimmune diseases mean. So all these autoimmune diseases are targeting different antigens or proteins in each part of our body. So if desmosomes are attacked, antibodies are produced against desmosomes, then these antibodies will destroy the desmosome. So cell-to-cell attachment will be lost. That process is called acantholysis, and that is what resulting in a disease called pemphigus. Whereas if the basement membrane components are destroyed by the autoantibodies, then you will get another type of autoimmune disease which is called as pemphigoid. Now why I am telling about all this is because all of these diseases are autoimmune disease. So the pathogenesis is that they are all autoimmune diseases. But when you know that against which component the autoantibodies are directed, you can naturally tell the clinical feature and course of the disease, because clinically all these are vesiculobullous lesions. Because whenever there is destruction of the antigen by the antibody, a split is created either within the epithelium or in the subepithelial layer that is clinically translated as a vesiculobullous lesion. So the patient will come to you with a vesicle or bulla in the oral cavity. When you take a biopsy, you will see a split either within the epithelium or in the subepithelial layer. If it is within the epithelium, you will call it pemphigus. If it is in the subepithelial layer, it is predominantly pemphigoid. So here, if you understand the pathogenesis, it is easier for you to even tell the clinical features. You don't have to by heart any clinical features. You don't have to by heart any management. If you understand the pathogenesis, you yourself can think and tell the clinical features. And of course, autoimmune disease means the immunity is becoming hyperactive. Therefore, the treatment will naturally be immunosuppressants. Corticosteroids are the most commonly used in the treatment of all autoimmune diseases because that is what is suppressing the immunity. So the point I am trying to make here with this slide is that if you understand the pathogenesis correctly, that will help you tell the clinical features, and that will also help you guide the prognosis and management of the patient. So oral pathology is not an individual subject, but it has got interaction with all the other subjects that you're going to study in your final year and third year, like your periodontics, oral surgery, pediatric dentistry, and conservative dentistry. Now in conservative dentistry and endodontics, dental caries, pulpitis, and periapical lesion is a big. Without caries, there is no conservative dentistry and there is no endodontics. I think all of you will agree with that. Dental caries is the main crux of conservative dentistry. The pathology or pathogenesis of dental caries is what the pathology is going to tell you. Without knowing how caries occurs, without knowing what is pulpitis, what are the types of pulpitis, what is a periapical lesion, how periapical inflammation happens, what is a phoenix abscess, without knowing all this pathology, you will not be able to understand and study about conservative dentistry. Yes? So if you know the pathology properly, it will also help you in understanding the other subjects in dentistry, like your conservative dentistry, pediatric dentistry, perio, and your oral surgery. Now with all that, in my personal experience over this 13 years, what kind of advice and what kind of guidance I have been giving my students for cracking the exams, I'm going to share with you. But before that, you need to know all of us are not the same. Not only in physical appearance, I'm not talking about physical appearance, even the way we approach the subject and our learning abilities. I think Dr. Ramya will agree with that. We have a lot of category of students, right? We categorize them into slow learners, advanced learners. Yes, so we need to understand that all of us do not have the same ability. So when it comes to an MDS aspirant who is trying to prepare for the exam, from my own experience, I have seen 3 groups of people. The first group, highly motivated. If we have I used to come from Kerala to Chennai because I'm coming from a very long distance. They used to give me 2 classes together, Saturday and Sunday, morning 8:30 to 5:30. Only 1 hour lunch break in between. So we used to have front and back classes. So this group of students, the entire time they will be sitting in the front row. They'll be having a notes with them. They will be very attentive. They will be listening to whatever we say. They will not sleep. They will not, nothing. They'll be very attentive. These are self-motivated children. You don't have to do anything about them. They wanted to get MDS, they are ready to work for that, they have come for that. So they'll be there. That is only 10%. You have another 10%. Whether it is in the front or back seat, they will be sleeping all the time. They are not bothered whether I am looking or not looking, whether the next person, they'll be falling on the next person also, not bothered, but they'll be sleeping. Those kids are forced. The parents would have told, already I spend lakhs and lakhs for you for BDS. Now again MDS also I cannot spend lakhs and lakhs. You try to get some good seat by joining MDS. Go and join some institute and study. They would have forced the kids and sent them. So this 10% are forced who don't have any interest to study nor joining MDS, but because they have been forced, they'll come there and sit. But the remaining 80% are majority of them. They are average students. They have some kind of self-discipline. They will do what majority of the class students do. Yes? But as Dr. Singh told, this average student can be turned into a topper. If you take the history of the 13 or 15 years of NEET MDS, whoever has cracked the exams and got the first 10 ranks, hardly anyone will be a very good student. Around 8 out of 10 will be an average student only. So what I'm trying to tell here is, don't think that you should be a motivated student to crack this exam. Not necessary. You can still be an average student and you can become a topper. How do you do that is the question. There is no shortcut. Only one straight way. That way is hard work. So I'm not here to teach you any shortcut or any tricks where I can tell you, no, you do like this, you will get the exam. No. I can tell you only one straight path, that is hard work. So the 3 important key of turning an average student into a topper and cracking this exam is not only hard work, but it is also dedication and consistency. You know what is consistency? Now this institution, Savita Dental College, consistently is topping and getting NIRF ranks. Yes? How do you think that is possible? One person, Dr. Deepak, is sitting in his room and he is thinking that my college should be a topper. Can the college become a topper? No. Can never happen. He has to communicate that to all the staff members. All the staff members should put in their own effort, hard work, and that has to be translated into an active work. Only then this will happen. So that consistency is very, very important. Today you do it. Oh, today ma'am has told we have to work hard. That is enough. Today I go and read for 2 hours and tomorrow whole day I am sleeping. It will not work out. So you need to work hard and that hard work should be a consistent thing. So 2 important things for preparation for exam is time management and good study materials according to me. So time management means everyone will think how much time is needed for preparation. I told I prepared for 1 month and I cracked the exam. That must be because of luck also, I don't know. Or there is another reason. I was trained in such a way in Savita Dental College that my basic was very good. That I really didn't need so much of preparation. That may also be another reason, but I don't know. But it will not work out for everyone. So if you really ask me how much time you need, it depends on whether you are going to prepare in the internship and immediately give the exam, or you want to take sufficient time 1 year after internship and then prepare for the exam. Accordingly, you can take the time, because if it is internship, I know in Savita, the interns are really busy. You have a lot of work to do. So you will not really have much time to read. But if you complete your internship and sit and prepare properly for 6 to 8 months, then you will have sufficient time. And study materials, lots, thousands and thousands of study materials are available online. But in my experience, I would recommend these books, especially like what Dr. Singh told. Dental Triplet is an excellent book. We have been recommending that for all our students because it gives you all the NEET-based questions. You will get an idea of what type of questions are expected in the exams. And you have a couple of other books also. Specifically, you have some books for basic science, because how many of you find biochemistry very difficult? Let's be true here. Biochemistry, how many of you find it very difficult to study or understand or reproduce in the exam? 3 or 4. Pharmacology? 3 or 4. So others are happy and fine with biochemistry and pharmacology. I'm surprised because in my class and my students, if I ask, literally every one of them will raise their hands for pharmacology and biochemistry because we deal it in a theoretical way. Biochemistry means it immediately comes to my mind cycles and cycles. Thousands of enzymes. I need to remember all this. So it is very difficult for me. Correct? But biochemistry is not that. Biochemistry is a beautiful subject. It is something called clinical biochemistry, where for every cycle that you read, there is a clinical relevance. So we are being focused on the cycles and enzymes. No one is emphasizing the importance of clinical biochemistry. That is why we find it very difficult. So whenever you are reading itself, there are many basic science books which gives you the concept of clinical pharmacology, clinical biochemistry, and gives explanation for all this, why this is happening, what is the importance of G6PD. Anyone knows what is G6PD? Glucose 6 phosphate dehydrogenase. It's an enzyme. We read that in which cycle? Krebs cycle. Why is that enzyme important? Why is that cycle important? Go back and read. So that is how you are supposed to read biochemistry, not just by heart the list of enzymes. Another question everyone asks is it okay that if I read only MCQ questions? Lot of books are there, lot of mock questions are available online. So I can, because do you have MCQ based questions in Savita? You don't have, right? Objectives, you have fill in the blanks, but not MCQ questions. So you are not trained for this MCQ questions. What is the difference is when I'm reading a textbook about one particular topic, if I have MCQs for my exam, I will read it accordingly. But if I don't have or if I'm not trained for MCQ, suddenly to attempt that questions will be difficult. But according to me, MCQ based questions are the easiest of all. Why? all the answers are there in front of you. You only have to choose the right answer. Whereas all the other type of questions, even for fill in the blanks, I have to think the answer and write it on my own. But for MCQ, already the answer is there in front of you. You have to tick the right answer. So that is one of the easiest thing to answer. So take it in a positive way. And it is very, very important that you have a good basis or foundation of the theory. Without theory, just reading the MCQs will not help. That will never work when you read for MDS exams. The next question many people ask is, there are some students who do self-study. They may be a motivated student. So can I just read it myself or should I join a coaching center? I would recommend, if it is possible, please join a coaching center because that gives you a guidance. There is always someone behind you to tell you what to do, how to study, what kind of materials you can use. A proper guidance will be given, and there is something called fear psychosis. You know what is fear psychosis? Now everyone is having the same kind of motivation that I have to crack the exam, I have to crack the exam. So when you are amongst those kind of people, you will also automatically get that motivation. So whether it is offline or online, which institute, I am not recommending any particular institute. Whatever is convenient for you, whatever is practically possible for you, you can go for that. But if it is possible, try to join a coaching institute. I'll just take 5 more minutes and I'll finish it. Some simple tips from my own experiences. Make a timetable. See, suppose you have the exam is in March. You have 3 months. Make a timetable for 3 months. All the subjects have equal importance. So make a schedule. Per day, I'm going to prepare for 3 hours. 1 hour is for anatomy, 1 hour is for physiology. Make a timetable. Don't stop with that. You have to adhere to that timetable. Just making the timetable and sitting and seeing that is not enough. You have to follow that. Give equal importance to all the subjects. You saw that subject-wise distribution. Everything is having equal marks. So you cannot have one subject more importance, the other subject you cannot leave it. So every subject you have to give equal importance. Then focus on weak subjects. I mean there are some subjects which you are weak in. You know that. I am weak in biochemistry. I know that. So I'll give more importance to biochemistry because I didn't read that properly in my undergraduation. So I will give more importance. So everyone, you know your own limitations more than others. So give importance for the weak subjects. Study, make a study group. 10 years back, 10 of us used to form a group. They used to sit together in MGR University and prepare for the MDS exam. Okay? Why that group is very important is when you're sitting alone, getting the focus and concentration is very, very difficult. Every 5 minutes once you want to check, install some update, whether I've received some WhatsApp message has come, let me check this, let me see this. That is a temptation for every one of us nowadays, right? So, but when you are in a group of 4 or 5 people, you will have that interaction with each other. Remembering is also very easy because you will relate that your mind and brain will work in such a way. Yes, that day when we were sitting together, Shamla told me that always cockeye means it will be broad or cockeye means it will be spherical in shape. That kind of comparison and remembrance, it is easy to get when you do a group study, and concentration also will be better. Even if you're trying to daydream also, your friend will say, you shut up and listen to what I'm saying. Yes, so that kind of advantage you have. So if you have good-minded friends who are also motivated, form a small group and do a group study. Good study material is important, and I guess revise. That is very, very important. So when we are preparing for this exam, have you heard about this mnemonics? There are many people who are very fond of this mnemonics. They will have the short forms for everything. I used to have a friend with me. I will not mention his name. He's very fond of mnemonics. For everything, classification, everything, he'll make mnemonics. And he has a book for mnemonics where he has written all the mnemonics. But at the end of the day in the exam, he will remember only the mnemonics. He will not remember any of the full forms. So when you are also preparing the mnemonics, make sure if it is only helpful, if you will remember, you can try that. I will never forget this mnemonic because at this moment I take this opportunity to remember my old anatomy madam, Dr. Sharda Kadiresan. She is no more. She used to take anatomy for us. She used to teach us this mnemonics for branches of external carotid artery. Sister Lucy's powdered face often attracts medical students. I will never forget this mnemonics. I still remember, though I'm a pathologist, I still remember all this. Anyone can tell what does each of this stand for? External carotid artery branches. Superior thyroid, lingual artery, posterior auricular, facial, occipital artery, ascending pharyngeal, maxillary, and superficial temporal artery. So for every small things, if it helps you, you can follow this tip. Dr. Ramya, stop. Yes. Yes. And sometimes in pathology, what happens? There are a lot of lesions with lot of clinical features and histopathological features. You find it very difficult to remember what is what. So those kind of things, you can always make a comparison. For example, we have 4 benign epithelial odontogenic tumors: ameloblastoma, calcifying epithelial odontogenic tumor, squamous odontogenic tumor, adenomatoid odontogenic tumor. How do I remember is, all these are common in the posterior region of mandible. But there is only one exception to that, that is AOT, which is common in the anterior region of the maxilla. So when it comes to remembering things, you try to pick out the odd one and remember it, rather than by hearting posterior region of mandible, posterior region of mandible. No, same thing. If you take salivary gland tumors, according to the statistics, most of the salivary gland tumors are common in females. But among the benign tumors, only one tumor is common in males. Which one is that? Warthin's tumor. So try to remember the odd one out so that it will be easier for you to remember. And I used to make tabular columns like this. And I just used to take a printout or write it on a piece of paper. I'll stick it on my cupboard and walls. So every day morning when I'm brushing my teeth or when I get up, I just look into it. So what happens is some things automatically will enter your brain without even you realizing it. Yes? How many Tamil and Hindi songs do you people know by heart? How many songs do you know by heart? Tamil songs? 100, 200, 300? How many? So many, right? How do you think you remember all those songs and lyrics and tune? Today one new A.R. Rahman song is released. Today you are listening it on your earphone. Will you remember it the next moment? No. You keep hearing it again and again and again and again, right? So 3 days, 4 days, 5 days, you keep hearing it. 6th day, automatically I'll know the tune. Automatically I'll remember the lyrics. The same thing applies for everything. That's how the human brain works. One day, one moment I'm seeing this tabular column, immediately I'll not remember anything. Keep seeing it again and again and again. Then even without you realizing, these data will enter and it will be stored in your brain. That's how it works. So for those things which you need that comparison, see for this I'm telling human herpes virus, 8 types of viruses are there. They belong to 3 groups, alpha, beta and gamma. So the first 3, 1, 2 and 3 are alpha because the latent infection is in the neuron. So they are categorized as alpha. 4 and 8 belong to gamma group because the latent infection is in the lymphoid tissue. Whereas 5, 6 and 7 belong to the beta group because the latent infection is in the salivary gland. So you categorize according to your own convenience and make it into simple flow charts and tabular columns. Take a printout and stick it on the place where you will daily see and you will remember. So you need a constant force to move ahead in the dark path of any exam preparation, not only NEET MDS, any exam preparation, so that if you have to reach the light at the end of this tunnel, that path is very difficult to travel, but still it will be possible and it can be done if you have that constant motivation, dedication, consistency and hard work that I mentioned. There is nothing else. I always, every first years when they come, we have an orientation program. I tell only one line to all of them. You don't need to have an IQ of Albert Einstein to study dentistry. Sir, am I correct, sir? You don't need to have an IQ of Albert Einstein to study dentistry. Everyone can study dentistry. Not only study, you can become a topper. You can acquire the knowledge and skill only with 2 things, dedication and hard work. That 2 important key points, keep it as a take-home message if you are an undergraduate student to go ahead for your future. I want to wish every one of you all the best in whatever future endeavors you're going, be it any course that you're going to join abroad or crack a NEET MDS exam or join a government institution and work there. Whatever you're planning for the future, keep these 2 important things in your mind that if it is possible for the next person, it is possible for you also. That can be done only with dedication and consistency and hard work. So all the best to all of you. I entered this college 27 years back in 1997 as a first year BDS student. My father came and dropped me here and went. Now I would say that I've come a full circle. Now I'm standing here on this stage as a speaker. That is only possible because of the support, guidance and prayers of my parents. Definitely my teachers who are here, who are not here. And my special thanks at this moment to the Department of Oral Pathology and Biology, Dr. Pratibha Ramani, Dr. Ramya and all the other staff. And special thanks to my senior, Dr. Deepak and also Dr. Veerayan, everyone for giving me this opportunity. I am who I am as a person, as a human being, as a pathologist, as a dentist. That base and foundation was laid at Savita Dental College. And I'm very proud to say I am alumni of this college. Thank you for this wonderful opportunity. Thank you all for the patient listening.
It was a nice, enlightening lecture and very motivational one. Even I thought of writing once again the NEET It was wonderful. And the way you explained the importance of pathology is a wonderful one. And thank you very much. Anything from the audience? Thank you very much.
If you're not asking anything, either you're eager to go out and have your lunch, or you're happy you understood everything. I will assume that the second one is correct.
We have another award announcement. I would request Professor Dr. Shivbad Sundaram sir to do the honors. I call upon the stage. We have one more best postgraduate student, Dr. D. Ramya, to please come over the stage. She is from Balaji Dental College. There's a special mention about her. She has, being a postgraduate student, she has already contributed to 2 textbooks from her department, which is highly commendable. She deserves a special applause. Thank you. The idea of having this career enhancement program in oral pathology and biology conference is mainly to kindle the interest about pathology amidst the young minds, and also to enlighten about the subject. So that is why we have specially dedicated a portion of this program towards career enhancement for undergraduate program. So that is why, and now we'll break for lunch. Please take a very quick break and please assemble back for very intense lectures, keynote lectures lined up from 1 p.m. We can break for lunch now. Thank you. சார் உங்கள் இது மட்டும் இருக்கேன் டாப்
அந்த ரெண்டு ஃபோன் ஃபர்ஸ்ட் இதாக்கி ரெண்டாவதா போட்டு விட்டு
We are now beginning the post-lunch plenary session. This is a very intense topic, and we have with us an expert to address this issue. Metabolic hygiene hypothesis. Just look at the way the title is framed. It's so, I feel, very inquisitive title. So metabolic hygiene is everything what disease is all about. And if you have the smartness to have your metabolism hygienic, hygiene அப்படின்ற வார்த்தை சார் அரவிந்தன் சார் இட்ஸ் வெரி க்ளோஸ் டு அவர் ஹார்ட் ஆக்சுவலி especially as dentistry, and it's a game changer in the field of diabetes, the most common disease in India especially. We know that we are the diabetic capital of the world, so every one of us should be aware about this, and it's a most important topic to us oral pathologists as well. So we have with us an expert speaker in the area of genetics and biotechnology. Dr. Aravindan is currently an assistant professor in the Department of Genetics from the prestigious ALMPG IBMS University of Madras, Taramani campus. He has obtained his PhD in molecular immunology and vaccine research. And he is from the Department of Immunology and Tuberculosis Research Center. And he did his postdoctoral training from USA and the National Cancer Institute of Health, USA. His area of specialization are molecular biology, immunology, and genetics. And these three key words, sir, it's very common between oral pathology as well. So we're really waiting to listen to you. And sir was also the recipient of Best Researcher Award for the year 2018. And he received it from TNCM at the University of Madras. And believe me, participants, it's not an easy award to win. It's such a difficult award, especially amidst the very tough environment of University of Madras. And he also won the same, he had another award with the Diamond Jubilee Year Celebration and Tulir 2021. Again, he won a Best Researcher Award. He also won the Biotech Startup Seed Money provided by RUSA version 2 program, University of Madras, where he serves as a role mentor. I know sir from almost more than a decade now. It was in 2014 that I listened to him, and we were very inspired by his lecture. And it has been a decade since I listened to him, waiting to listen to you, sir. Over to you, sir.
Yeah, very good afternoon, one and all. And first of all, I'd like to take this opportunity.
This session will be moderated by our respected Professor Shamala ma'am. Shamala ma'am is a professor and head of Adiparashakti Dental College, Melmarutur. So ma'am will be chairing the session. Ma'am is also interested in dysbiosis, which again is very close to this topic. Thank you, ma'am.
So first of all, I'd like to take this opportunity to thank Dr. Ramya for giving me this opportunity to share some of my knowledge with you. And even before starting with the presentation, I would like to start with an apology because I know this is a dentistry conference and the topic which I'm going to discuss about has absolutely no relevance to dentistry or dental health and things like that. But as ma'am rightly pointed out, diabetes is a major problem, and I know even for dentistry it is a really major problem. In fact, if I remember right, just about a decade ago, oral hygiene was found to be strongly associated with, increased risk of diabetes. So they found out like when individuals who do not maintain oral hygiene, they end up with lot of inflammation. And this inflammation makes individuals more, associated with diabetes. And another thing, diabetic people generally tend to have poor immunity. So that would also compromise their oral immunity, and then they are more prone for, tooth loss, canaries, and things like that. So this is a bidirectional interaction between dentistry and diabetes. Of course, I'm not going to touch upon that one, But since at least diabetes component is kind of closer to you, I feel like this would be interesting to you. So this is basically a serendipitous finding which was identified in my lab about a decade ago. So basically I'm an immunologist and I decided to work on diabetes, which is a major metabolic disease. And being an immunologist, I was interested in two different aspects. One is immunity, compromised immunity among diabetic people, which has been very well documented. The other one is chronic inflammation, which was a fast upcoming field about a decade ago and even now, and how inflammation kind of make individuals more diabetic. Okay, so these are the two fields which I was interested in. And because I was trained in tuberculosis research, I first concentrated on diabetes tuberculosis. Of course, what I'm going to talk to you now does not have much relevance to tuberculosis, but the second component, diabetes filariasis. So filariasis is a very unpopular disease as of now, but you will see like it is a multifaceted disease which intervenes with diabetes at multiple points. Okay. So let me start off with a very, very simple, straightforward question. You could obviously see the difference between the first picture and the second picture. The first picture, obviously, most of you would have guessed, if you are from Chennai, it is nothing other than that, or, Ranganathan Street, which is very close to our heart, and always crowded, always busy, always buzzing with people and things like that. The second street is one of the streets in New York, which is very clean and things like that. So madam already said, like, she being a dentist, you always get attracted towards hygiene and things like that. But today I'm going to talk to you about how too much of hygiene can actually be, like counterproductive or can actually compromise your health. So that is what is hygiene hypothesis. So the hygiene hypothesis, okay, what it basically says is too much of hygiene is actually not too good. Okay, so clean streets versus dirty roads. So the hygiene hypothesis per se is not a very new concept. It was first put forth by a statistician by name David Charcharan in the year 1989. Okay, so of course I'm not going into the details of all the details of hygiene hypothesis, but it's a very interesting hypothesis. Okay, you can go back and read, and there is a very interesting history behind that one. Now, David Charcharan is basically not an immunologist. He was basically a biostatistician working for epidemiology. But how is it like he came up with a hypothesis which has so much of relevance and application in immunology? I mean, that is still one question which always daunts me even till now. The task which was given to him is that when he started this project, there was a sharp increase in autoimmunity as well as allergic diseases in Britain. And then there was a sharp decline in infection diseases. So the British government basically wanted to know what could be the reason why there is a sharp increase in allergies in London. Okay, that's how it all started. So he collected data from so many different families, and then he did all kind of complicated data analysis, and then he came up with a finding saying that allergies were definitely much more common in nuclear families compared to compound families or joint families, as we would call now. Okay, and because of industrialization, more number of nuclear families were coming up, and this could be the reason for allergy. So that is the statistical observation which he had. But the thing is, how do you explain this one from the biological terms? Okay, so he was unable to explain this one from the biological perspective, and of course others came into the picture, and then they said, like, in a larger family, the growing up children always have the opportunity of going out, getting infected, coming back, passing on the infection to the newly born children and things like that. So when children are exposed to infections at an earlier time point, their immune system somehow trains itself, and then it trains to differentiate between good and bad. That is very, very important. But what happens in nuclear families, because like the socioeconomic status is so high, extreme hygiene is followed and things like that, even if there are one or two grown-up children, before they go in for the newly born children, they would be asked to wash their hands, take a bath and things like that. And then the newborn child doesn't have an opportunity to get infected. So when the newborn doesn't get infected at an early time point, the immune system loses its ability to differentiate between good and bad. And he proposed saying that this inability of the immune system to differentiate between good and bad is a basic reason why we see so much of allergies suddenly coming up in the industrialized London. Okay, and in 2004, this was extended to autoimmunity also, because allergies and autoimmunities are always kind of linked together. Both of them, allergies occur because of hyperstimulation of the immune system. Okay, so we call it as hypersensitivity. And autoimmunity is when the immune system starts fighting back on its own body components. So I have told you most of the things. Childhood infections are needed to train the immune system. So this is a basic concept on which I'm going to build my story. In the absence of childhood infection, the immune system loses the power to differentiate self and non-self. Decrease in infections were found to increase the risk of allergies and asthma. Later, the same phenomenon was found to be responsible for the sudden increase in autoimmune diseases. So even now, if you go, autoimmune diseases are much more common in the Western world compared to the Asian countries. And one of the main factors that has been attributed is basically because of too much of hygiene which is being followed in the Western world. Okay? Now, having said this, does this hypothesis really have any relevance for clinicians, especially for our country, for the society and things like that? Yes, it was the, like 50 to 60 years is there. Because of rapid increase in the field of science, the incidence of infectious diseases have started coming down drastically. Of course, this is not uniform. You can still see infectious diseases are a major problem in developing countries, especially African countries. But in European countries and things like that, US developed countries, the infectious diseases has come down drastically. But apart from a drastic decline in infectious diseases, this has already been clubbed to a sharp increase in non-communicable diseases, especially metabolic diseases. So you could clearly see in whichever countries which you have high incidence of infectious diseases, there is low burden of metabolic diseases. In countries where there is high incidence of metabolic diseases, there is low infection or no incidence of infectious diseases. So there is a reciprocal relationship between these two components. Okay. Now, where does India actually stand by? India is actually standing in the transition state where, because of better medical practices, the infectious diseases have started drastically coming down, especially diseases like filariasis. But we are witnessing a sudden shoot in metabolic diseases, especially diabetes and hypertension. Okay. So what is extended hygiene hypothesis? The hygiene hypothesis, which was extended to include metabolic conditions like obesity, was called extended hygiene hypothesis. Initially, the hygiene hypothesis was put forth to explain the increase in allergies and autoimmunity. Later, the same phenomenon was found to be responsible for the increase in obesity in certain populations. Obesity predisposes obviously to metabolic complications such as insulin resistance and dyslipidemia. So I started working on diabetes, and all of you know, like diabetes is broadly classified into three types. We have type 1, type 2, and and gestational diabetes. Type 1 is very, very low prevalence, and in India it is less than 1 to 1.5%. The major component is type 2 diabetes, and gestational diabetes is just a transition diabetes which occurs only during pregnancy in some women. Type 1 diabetes is a bona fide autoimmune disease, and it arises due to autoreactive T cells as well as B cells. Now, these cells lodge in and destroy the pancreatic beta cells, which results in the impairment of insulin production. So, in the absence of insulin, obviously type 1 diabetes develops. So till now, no cure is available for type 1 diabetes, and the autoimmunity is basically due to genetic and environmental factors. And in the environmental factor, that is where your hygiene component is coming into the picture. It has very low incidence in India. So as I told you, the most common form of diabetes in India is type 2 diabetes. Type 2 diabetes, the target cells become resistant to insulin, which is basically due to inflammation. So insulin resistance leads to impaired glucose tolerance, which in turn leads to type 2 diabetes. And the exact immune mechanism behind this one is not known. T2DM is a chronic inflammatory disease which is associated with chronic non-specific low-grade inflammation. And inflammation, whether it is a cause or consequence of diabetes, that is an unanswered question. Further, the effect of this hyperglycemia or diabetes on immunity into infection is largely unknown. Gestational diabetes, as I told you, it is transient diabetes which affects only some pregnant women, arises due to hormonal imbalance which is seen during pregnancy, leads to pregnancy loss, pregnancy complication, and also compromises the adult life of the child born. Okay, now I am shifting my gears and going to talk to you about filariasis, because we are going to see the interface of filariasis and diabetes. Lymphatic filariasis is commonly called as elephantiasis. India is endemic for LF for about with about 553 million people at risk of acquiring the infection. It is mainly transmitted to mosquitoes. Infection takes place during childhood, but disease manifestation is seen only in adults. LF causes significant morbidity, but not mortality. The prevalence has decreased drastically in the past few decades due to mass administration of anti-helminthic drugs. So here, the most important 2 points which I would like you to remember are, infection takes place during childhood, but disease manifestation takes place only in adults. The second thing is the prevalence has drastically started going down because of mass administration of anti-helminthic drugs. So a parasitic disease caused by thread-like worms living in the human lymphatic system, transmitted to mosquitoes, endemic in 83 countries, major cause of permanent disability and disfigurement. Adult worms damage the lymphatic system, causes fluid accumulation and causes swelling. Okay, so where it all started? Because first I was employed as a scientist in Meta Diabetic Research Foundation. So at that time, they have actually completed a huge epidemiological study called CURE study. So the CURE is an abbreviation of Chennai Urban Rural Epidemiological Study. Okay, so you can see the huge number of patients who have been screened. And then the study was carried out at 4 different phases. So basically, it was a study to estimate the prevalence and incidence of type 2 diabetes in Chennai and associated area. So as part of the study, they actually had a huge serum bank, which was a gold mine which was available to me when I actually joined the institute. So the first question which we asked was, because diabetes compromises immunity, we are expecting a high prevalence of filariasis among diabetic patients. That is what would be normally expected. So we wanted to see whether any studies have carried out wherein they have looked in for prevalence of filariasis in diabetes. So at that time point when we looked at the literature, no study was available. So our initial hypothesis is that diabetes compromises immunity, which would make individuals more susceptible for filariasis, and hence the prevalence of filariasis should be higher among diabetes. But just look at the first figure. Even in the first figure, we were so drastically, down, because it was completely, against our initial hypothesis. In fact, our hypothesis was found to be wrong. Why? Because NGT is normal individuals, IGT is pre-diabetic, DMNT is newly diagnosed diabetes, KDM is known diabetes. And you can see as we go higher with respect to your insulin intolerance or glucose intolerance, the prevalence of diabetes was actually falling down. In other words, if the prevalence of diabetes is 10% in the control population, it was less than 5% in the KDM or the non-diabetic population, and this difference was statistically significant. So as I told you, this was the first result which helped me to embark on the hygiene hypothesis, because this was totally unexpected. We tried to find out how is it diabetic patients had lower prevalence of filariasis. So this is where I did little bit of background study, and then we formulated that in endemic zones like India, the moment the child is born, it is immediately bitten by a mosquito, which means it is automatically infected by the lymphatic filariasis parasite. Now what happens is, even in those who are infected, only around 5% will develop the disease. But what happens to the remaining people who got infected? They just clear the infection or remain infected, provided their immune system is intact. Okay? But what happens is, this filarial infection is very, very different from that of your bacterial and viral infections. How? Because bacterial and viral infections are known to increase your inflammation. That's why you see acute inflammation in HIV patients and viral diseases and things like that. Whereas filariasis is very, very unique because it is supposed to downregulate or suppress your inflammation. Because Filariasis is known to be associated with immunomodulation. So the logic is, when filariasis suppresses your inflammation, it is automatically suppressing your insulin resistance. When insulin resistance goes down, automatically your chances of getting diabetes also goes down. So that kind of explains the inverse relationship which we saw between filariasis and diabetes. And then of course we looked at antibody titers. We also looked at few inflammatory markers, and as you can clearly see, DMLF negative, DMLF positive means diabetic patients who are filarial negative and filarial positive. Even though both of them had significantly higher level of few of the inflammatory markers, those who had filarial positive actually had lower levels of this cytokines, which clearly indicates that filariasis has a unique ability of suppressing the inflammation, which is mainly attributed to its immunomodulatory effect. So having got the first publication, then we wanted to look at type 1 diabetes, and as you can see, we screened around 200 type 1 diabetic patients and none of them were LF positive. Okay, so even though some of them have already been exposed to LF. So having got very good results with type 1 and type 2, we looked in for a related condition called CAD. CAD is coronary artery disease, which is also a metabolic disease. But this is where the uniqueness of nature is coming into the picture. Even though technically you can classify diabetes and CAD together as metabolic diseases, the inflammation associated with diabetes is very different from that of the inflammation associated with CAD. So as you can see, there was no difference in the prevalence of diabetes in control individuals as well as the CAD positive individuals, which clearly tells us that filariasis, even though is immunomodulatory, is able to downregulate the inflammation associated only with diabetes, not the inflammation associated with CAD. And the same picture was also, like shown in the inflammatory markers which we have looked at, like TNF alpha and IL-6. And as you can see, there is very little change between both the groups. So again, we are coming back to the hygiene hypothesis, but we are redesigning the hygiene hypothesis, which has already been extended to autoimmunity as metabolic hygiene hypothesis. So an inverse relationship between the decreasing prevalence of helminth infections and increasing prevalence of metabolic diseases is called as a metabolic hygiene hypothesis. The etiology of several metabolic abnormalities has recently been linked to chronic low-grade inflammation. This inflammation is distinct from acute inflammation seen in infectious diseases and has been termed meta-inflammation. Meta-inflammation leads to insulin resistance, which is a major etiological factor for type 2 diabetes. Helminth infections are largely immunomodulatory in nature and inhibit meta-inflammation. By inhibiting the meta-inflammation, it reduces IR, conferring protection against metabolic diseases. So this is the metabolic hygiene hypothesis in nutshell. So now let's look at the possible mechanism involved. So as I told you, even in 1989 itself, the hygiene hypothesis was put forth, which clearly said like infections like filarial infection can confer significant protection against allergies and autoimmunity. But what we showed was the filarial infection by means of immunomodulation, of course, at least few of the immunomodulatory pathways I have listed here, which include tolerogenic dendritic cell, Th2 cells, alternatively activated macrophages, TLR pathway, Tregs and INK2, they can actually inhibit the meta-inflammation associated with type 2 diabetes. So when the meta-inflammation goes down, insulin resistance goes down, this reduces the risk of metabolic syndrome, which is a more aggravated form of your type 2 diabetes. Metabolic syndrome is nothing but type 2 diabetes with other metabolic comorbidities. So this is what we call it as metabolic hygiene hypothesis. So this was highlighted at that time in the Economic Times of India. I also had the privilege of visiting the California Institute of Philatron and delivering a keynote lecture there. So these are all past stories. So in another 10 to 15 minutes, I will try to explain to you what is the latest things which we have achieved in this particular field. So again, we went back to the cures cohort because already we have done an epidemiological study. We have already identified the patient. But at that time, it was a cross-sectional study because we have taken the patients, screened them for filariasis, and tried to find out who is positive, who is negative, did some serum biomarker analysis, and with that we have framed the hypothesis. Now we wanted to make it as a longitudinal study. We wanted to go back to the patients and try to see what really happened to those patients who are diabetic filarial positive, diabetic filarial negative. So as you can see, there are two groups. The NGT group or the normal glucose tolerant group, which is the control group, and we have the DM group or the diabetes group. Both the groups were followed up for 10 years. Blood was collected, and then we did both ex vivo study as well as in vitro study. So in ex vivo study, the cells were just taken, stained, or RNA was extracted and things like that, and there was no culture involved. In the in vitro study, we actually separated the cells and cultured them under two different conditions. One is to study innate immunity, where we use TLR pathway. Another one is to study acquired immunity, where we have used BMA. BMA is nothing but Brugia malai. Brugia malai is a causative organism for filariasis in animal model. So it is an antigen which was used to study acquired immunity. So after in vitro culture, the cells and supernatants were separated, and in the supernatant we estimated large number of biomarkers including cytokines and chemokines. From the cells we did flow cytometric analysis as well as qRT-PCR analysis. Then we had the plasma where we have looked in for cytokines, chemokines, hormones, growth factors. We also looked in for redox markers, LPO, PPO, and nitrate. And in the ex vivo study, we specifically concentrated on the Treg population. Why? Because as I have been constantly implementing, we have meta-inflammation, we have immunomodulation. The key players of immunomodulation with respect to filariasis is your Treg population. So if the Treg population is high, automatically immunomodulation is high, and your meta-inflammation would be low. Okay? So first we looked at cytokines. As you know, cytokines are basically molecules which are involved in immune cell communication. I'm not going into the exact details of all those things because that would be too much of overwhelming. So I'm just going to give you a nutshell about the important components which we have identified. And as you can see, this panel kind of covers almost all the important cytokines pertaining to pro-inflammation as well as anti-inflammation. TNF-alpha, IL-6 and IL-1 beta, they are all pro-inflammatory cytokines. IL-10, IL-1RA, TGA-beta are all anti-inflammatory cytokines. IL-27 is a recently discovered anti-inflammatory cytokine. Interferon beta is actually a type 1 cytokine, and alpha defensin is a defensin molecule. But overall, as you can see, in almost all the groups, only LF positive subjects had significantly higher level of this cytokine. So here, we are not interested in that one. We are interested only, say for example, IL-1 beta. You could clearly see, compared to LF positive, the DMLF positive subjects had significantly lower level of the cytokine. So these are the specific biomarkers which we are looking in for, because they are the ones which will tell us the mechanism behind. Okay. For example, even alpha defensin, you can see like compared to LF in DMLF, alpha defensin levels were significantly reduced. So then we looked at adaptive immune cytokines. These are also cytokines, but they are predominantly secreted by your T cells. So in the first panel, we have IL-12, interferon gamma, IL-2, which are called the Th1 cytokines. In the second panel, we have IL-23, IL-17, which are called the Th17 cytokines. IL-9 is called a Th9 cytokine. IL-33 and IL-4 are called as Th2 cytokines. So again, we are covering almost all the important components of adaptive immune cytokine. Again, we got more or less the same pattern. As you can see, LF being a parasitic infection, the cytokine levels were much higher in this group compared to the non-LF groups. So then we looked at chemokines. Chemokines, as you all might be knowing, are low molecular weight proteins which would attract the immune cells. So they are necessary for immune cell communication. So we looked at 5 different chemokines: IL-8, IP-10, RANTES, MCP-1 and STF-1. And you can again see like the chemokine pattern is also very, very similar to that of your cytokine profile. Again, the most important chemokine here is IL-8, because as you can see, IL-8 levels were significantly reduced in DMLF subjects compared to LF subjects. So only cytokines and chemokines which are specifically downregulated in DMLF, those are the ones which are the chief players in the immunomodulation. So then we looked at oxidative stress. So redox marker, lipid peroxidation, protein peroxidation and nitrates. Of course, no major difference was seen with respect to PPO, but as you can see with respect to LPO, there was a significant difference between LF and DMLF positive subjects. Then as I was telling you, we started looking at T cells because as you know, T cells are the major place of immunomodulation. Two different cells have been identified, Tregs and exhausted T cells. So we looked at both these cells. So this shows the flow cytometric analysis about how we went about gating the T cells and showing it. I'm showing it here. But as you can see, the exhausted T cell population was definitely much higher in the LF and DMLF group, where a Treg population did not show much difference between the four groups. So this is also interesting because sometimes we have to go back and reject our own null hypothesis, or alternate hypothesis. In the sense, whatever hypothesis which we frame need not always be turning true at the end of the experimentation. So when you have to reject the alternate hypothesis, we have to go and modify your null hypothesis. So that is the way the research progresses. So then we started looking at hormones. Now you might be thinking, when I have continuously been talking about immune markers like cytokine, chemokines and things like that, why I'm suddenly talking about hormones? We should remember like diabetes is an endocrine disease and we are talking about immunomodulation, which is predominantly mediated by immunoendocrine network. So there is no point in just looking only at the immune markers. We should also look at the endocrine marker to have a complete understanding about how the modulation is taking place. So here we broadly divided the hormones into two groups. Pancreatic hormones, incretins are the gut hormone, and adipocytokines. And you can see like insulin levels were definitely much higher in people who had MS. MS is nothing but diabetes with complication. And that is expected because they have insulin resistance as a major component. Their hormone levels would definitely be higher. But what was more interesting in the gut hormones, you can clearly see with respect to the gut hormone, LF positive MS patients had significantly higher levels of ghrelin, GLP and GIP compared to LF negative MS patients. So what does it mean? Now, when a person who is having metabolic syndrome is infected with filariasis, he is able to produce high amount of this gut hormone. So why is it important? These gut hormones are very important because now we know in the field of diabetes, more than your pancreatic hormone, the gut hormones play a more important role. Why? Because at one end, they can induce insulin secretion and at another end, they also increase insulin sensitivity. So you know like GLP-1 is already a drug which is widely being used against severe forms of type 2 diabetes. And then you have DPP analogs or DPP antagonists, which is nothing but antagonists which would enhance or increase the levels of GLP-1. Okay, so that way also we found out like compared to pancreatic hormone, the lymphatic filariasis made in immunomodulation involves your gut hormones. So these are the adipocytokines which we looked at, but no major difference was seen with respect to the adipocytokine levels. So this work, we got this one published recently. So then we shifted and started doing our in vitro experiments. So as I told you, in vitro we looked at two different panels. One is TLR panel, the other one is antigen panel. TLR panel, as I told you, toll-like receptors are innate immune receptor, which are major sensitizers of inflammation. So inappropriate activation of TLRs can lead to inflammation. So that is the logic why we looked at TLR. And in TLRs, we looked at two different TLRs, namely TLR1 and TLR2 and TLR4, because these two TLRs have been very well characterized and already been implicated in meta-inflammation. Again, the cytokine panel is more or less the same. So we had pro-inflammatory cytokines, anti-inflammatory cytokines, adaptive immune cytokines, type 1 interferons, and then we also had defensins, and of course, like few other molecules also we had. So this is with respect to the TLR profile compared to the adaptive immune cytokines. So this is with respect to the TLR profile pertaining to your chemokines. And here also you can see the same IL-8 is showing maximum difference with respect to our TLR study. So this is again reiterating the fact that IL-8 might play a very important role in this immunomodulation. So here for flow cytometric analysis. So here we looked at MSC and co-stimulatory molecules. So here, as I told you, we looked at effector enzyme, COX-2, FOX, HO, and IDO. Most of them are immunomodulatory enzymes, and we could see significant difference with respect to COX-2 expression. Then we looked at the master controllers of adaptive immune response. TBET is for Th1, GATA3 is for Th2, RO or gamma GT is for Th17, and HO is actually an immunomodulatory enzyme, and P47 is also a immunomodulatory enzyme. And as you can see, no major difference was seen pertaining to the master regulators of Th differentiation. Okay. So then we looked at CD4 positive T cells, because these cells are very, very important in conferring protection against infection. And again, we looked at the same panel, but here instead of your TLR stimulation, as you can see, we are using an antigen. So whatever immune response which we are looking at, it pertaining to with that of the antigenic response. So again, we looked at pro-inflammatory, anti-inflammatory. This is with respect to adaptive immune. And as you can see, significant changes were seen in the adaptive immune cytokines. And IL-9 was very, very distinctive. And as you can see, IL-9 levels were significantly higher in LF positive subjects compared to LF negative. And then chemokines, except for IL-8, none of the other chemokines were showing, IL-8 and STF1, other chemokines were not showing major difference. So then we looked at TH polarization, TH1, TH2, TH9, TH17, and CD69 is an activation marker for T cells. So all these things clubbed together, we got a major publication in Frontiers in Immunology. And I was also invited to write a book chapter on this particular thing. So we have recently published a book chapter. So with this limited time, I think I have given you a little bit of understanding about what metabolic hygiene hypothesis is, how it is relevant and important to the society, and at least the key mediators which we think might play an important role in the immunomodulation of filarias. So from here, where do we take? So every hypothesis, every observation should have some translational potential. So that is where the future work is being targeted at. So once you are firmly able to establish filariasis can actually reduce the burden of diabetes, the next question would be to identify the filarial antigens and characterize them. Once these antigens are identified and characterized, they can be used for two different applications. One is with the latest technology in vaccine design, you can actually incorporate the filarial antigen and come up with an anti-diabetic vaccine. Lot of work, we are not doing that one, but lot of work in the Western world is concentrating on this particular aspect. Another thing is filariasis also has so many low molecular weight compounds. If these low molecular weight compounds are identified and characterized, maybe we can develop better drugs against diabetes. So I have come to the end of the presentation, and I would like to acknowledge my collaborators. Dr. Mohan, who has been a very strong collaborator for me for more than a decade now. I started my career in his institute, and he was the person who gave me all the samples, and cure study was carried out at MDRF. Dr. Subhash Babu, he is the director of ICER facility at NART, a very good friend of mine and a very long collaborator. So he is basically a filariasis immunologist who was the person who, kind of triggered the idea in me to go in for filariasis and diabetes. And a major component of this work was done by C.B. Joy Manogar. In another 1 or 2 months, she will be submitting a thesis. So I would like to thank all of you for your patience. Thank you so much. If you have any questions, I'd be very happy to answer them.
Sir, we should really be very thankful for Oral Pathology Savita for giving us this opportunity to listen to you, sir.
Thank you, madam.
Extremely happy about the presentation, and we can understand how much of hard work you have put, the task you have really done to reveal to the world something which is hidden. We know that as far as we are concerned, as lay people, maybe about filariasis, we know it is a disease of social stigmas.
Right.
An elephant legs, nobody likes to be appreciated with it, right. Isn't it? So on today, I should say it is a little eye-opener of what we have said, but nobody would like to get that infection for the sake of giving up diabetes mellitus.
Exactly.
But diabetes mellitus being such a common disease, the whole world is very anxious, especially India. We are anxious to really see a day when diabetes is going to be down-regulated, sir, definitely. And your work is going to be really a good opportunity for it, I think, sir. Thank you so much for
you,
telling us in detail about your hard tasks, sir, for the entire masterpiece you have
Thank you,
delivered, sir.
madam.
Thank
So
you so much,
one
sir.
final word which I wanted to say is, of course, this question always comes to me whenever I give this presentation. So as a lay person, many people would ask me, do you think getting infected with filariasis is better than having diabetes? Will you advocate that one? So obviously nobody wants to get infected with filariasis. What we are trying to say is the mass drug administration which is being carried out, that could be actually one of the factors fueling the rapid increase in diabetes. So identify filarial positive patients, kind of follow them for a period. Those who have started developing the symptoms, catch them young and treat them. That would be the right approach. On the other hand, if you are going to do mass drug administration, persons who would be protected by the immunomodulation by filariasis, they would be losing that one. So that is the only point which I would like to insist on. Thank you so much.
Thank you, sir. Thank you so much.
I request Satish Muthukumar sir to hand over the session chairing certificate to Shamla ma'am. Thank you. Our next session is about symposia on orofacial pain. These two are by international speakers. The first speaker is from University of Maryland, USA, and the second speaker is from Leeds University, United Kingdom. So I invite Sandhya to introduce the speaker.
A very good afternoon to all the wonderful people seated here. It's my honor to introduce our next distinguished guest speaker, Dr. Swarna Lakshmi Raman. She completed her undergraduate and postgraduate studies at SRM Dental College, earning a gold medal during her postgraduate degree in oral pathology. Currently affiliated with the Department of Stomatognathic Function and Occlusal Reconstruction at Tokushima University, Japan. Dr. Swarna Lakshmi holds a PhD and is pursuing a postdoctoral fellowship. Her doctoral thesis focused on creating a neuropathic animal model and assessing the analgesic effect of transilast in the regulation of tetrahydrobiopterin synthesis. Dr. Swarna Lakshmi's impressive academic journey includes receiving the MEXT Japanese government scholarship for her PhD, the Young Researcher Award from the Tokushima University. She has also been honored with the Faculty of Dentistry Dean's Award by the same university. Dr. Swarna Lakshmi is a renowned speaker in various international and national forums, contributing significantly to the field with numerous publications. Today, we are privileged to have her join us online to share her valuable insights. Please join me in extending a warm welcome to Dr. Swarna Lakshmi. Over to you, ma'am. Host her, just change her.
Am I audible? Thank you. And good afternoon, everybody. Thank you for a very beautiful introduction. I'm very honored and pleased to be invited to be a speaker in the Savita conference. So today I'll be talking about the recent therapeutic option for orofacial neuropathic pain. Yes, ma'am.
Professor Shivkumar sir to moderate the session. So please come over to the stage. Shivkumar sir is the professor and head of the Department of Oral Pathology in Mada Dental College, Chennai. Welcome, sir. Swarna, proceed.
Thank you. So currently I'm going to be associated with Department of Neural and Pain Sciences in the University of Maryland. Before I go into the presentation, I would like to give a brief introduction. I did my BDS and Masters in SRM Dental College and also did Junior Research Fellow under Ramya ma'am and Dr. Rajkumar sir. And further to that, I moved to Japan for pursuing my PhD, where I specialized in the field of neuroscience, to be more specific, the orofacial pain. So a little about the research experience. In my undergraduation, I had the opportunity to conduct DNA instability staining studies for the patients in chronic periodontitis. And later, my master thesis was in serum and salivary progranulin levels in the orofacial oral submucous fibrosis. Further, in the JRF project, as I mentioned with Rajkumar sir and Dr. Ramya, we did a single unit wireless device for salivary stimulation. I'm sure that most of you are aware of this project, which is still undergoing, and we have published 2 papers related to this. And in the PhD thesis, I dealt with the drug Trenilast for treating orofacial pain. So about this study, I will talk a little later in my research. Before I move into the research, I would like to show you the brief about how this presentation would go about. I would like to introduce the definition of pain, a little about the neurophysiology so that the concept is well understood, the current classification and the research which I've been doing in the past few years. So pain has been defined by the IASP as an unpleasant sensory and emotional experience which is associated with or resembling that associated with actual or potential tissue damage. So the word pain itself has been derived from the French, the Latin term, which means suffering or penalty. I think it is rightly termed that the pain cannot be measured. To be very severe form of pain. And we would consider that very important for a dentist is that form of pain which is occurring in the head or in the orofacial region, they would report to a dentist. I'm talking about the routine clinical practices where a patient would walk in to the dentist with such a pain. Not always it is associated with but actually no. Sensory and autonomous neuropathy syndrome, especially the type 5. What happens is these children, they do not know or they do not feel any kind of pain. So imagine they keep getting hurt again and again. They have multiple injuries and sadly these children do not survive. Moving on to a little about the neurophysiology. I'm sure this is very basic. So the A alpha, A beta and A delta fibers and C fibers are there. And correspondingly, they are responsible for the short and fast wave. How does this pain transmit? So basically, when we have any kind of heat injury, example, say from a candle burn or any kind of fire injury, there are sensory signals from the nerve endings which reaches up the spinal cord to the brain. And through the descending pathway, we have the signals from the brain down the spinal cord to tell us to move, or that is the sensory reflex, the motor reflex, where we tend to remove our hand. So this is how the pain pathway works. We have the ascending pathway, which is through the spinothalamic tracts, and also the descending pathway where we have signals and it is transmitted down the spinal cord to the sensory nerve endings. So at each level, the treatment should be modified. Say if we have any injury or damage or any kind of neuro pain in the peripheral nociceptors, a simple anti-inflammatory drug would do. But in case if it is in the central region, we need opioids and also alpha 2 agonists. Another common term which is used in the pain related research is allodynia hyperalgesia. So allodynia is a reflex or a response to a stimulus which is normally does not cause any kind of pain, whereas hyperalgesia means a heightened response to a very normal pain. In case of any injury or the reflex or the stimulation is too much. So that is the difference between allodynia and hyperalgesia. So in case of animal studies, we have different tests to perform for allodynia and hyperalgesia. So there are different basic types of pain, that is the nociceptive pain, the inflammatory pain, and the neuropathic pain. So today in the research, I will talk more about the neuropathic pain. As I mentioned before, we have the ascending pathway and the descending pathway through which the pain is transmitted. So from the injury site, the pain is transmitted or the signal is sent to the brain to the ascending pathway, and we have the motor reflex sensation from the brain down the spinal cord to the nerve endings or the peripheral region to through the descending pathway. So Margot McFree rightly said that whenever the person says there is pain, it does exist. So we cannot measure it or know the value of the pain. It should be accepted from the patient's words. So current classification or the ICOP has given into 20 usually divided into 6 categories. One, very well versed with this, with the routine clinical practice, which is the dental pain. Besides this, we have many other conditions. So those are very important for us to be able to treat or identify correctly. I would say that only if we have a differential diagnosis perspective, we will be able to treat the patients with orofacial pain. So most of the not treated correctly prior to the patients coming to neuropathic pain specialty. So the other conditions associated are myofascial pain, temporomandibular joint pain, cranial nerve pain, that is the trigeminal nerve or glossopharyngeal nerve pain, and also we have the headache, mouth, persistent idiopathic facial pain, etc. Trigeminal system will result in transmission of injury signals via the trigeminal ganglion, which leads to orofacial pain. So one classic example I would say is trigeminal neuropathic pain. There are different other nerve pain as well, but one of the major reporting cases are trigeminal neuropathic pain. So it is considered, as such, the whole of neuropathic pain or the orofacial pain contributes about 16 to 33%, and 10% is considered to be chronic orofacial pain. So as I mentioned, one classic example is trigeminal neuralgia. So what exactly it is? The basic anatomy is when you have an injury or damage to the new and the mandibular division. And the cell body of this lies within the skull in the base, that is the trigeminal ganglion. So what kind of neuropathic pain occurs usually is one, the major cause is because of the compression of the nerve. So any branch, that is V1, V2 or V3, there can be any kind of compression which results in neuropathic pain. Another condition would be tissue injury, where it can be due to tumor lesions or infections. Further, some of the minor causes could be a trauma during tooth extraction, even during routine endodontic or implant placements. And other very minor causes include the metabolic diseases or neurotoxic agents. So definitely there is conventional treatment which is very successful in most of the cases. That is anticonvulsants, wherein carbamazepine has been routinely used and it is the gold standard. We also use analgesics, that is NSAIDs. But what is the drawback is that analgesics are basically non-steroidal anti-inflammatory. So it does not target the neuropathic pain. So they have limited efficacy. What about carbamazepine? They cause dizziness and drowsiness, whereas opioids, on a long run, we all are very aware that it creates addiction. Moving on to the surgical management, which has been followed, and more than 90% success rate is definitely reported. That is microvascular decompression. And most of the cases undergo, in case if it is compression of the nerve, definitely medical treatment does not prove to be effective. So for a long-term relief, they undergo microvascular decompression. And definitely other surgeries like stereotactic, and also we have the neurectomy. But the disadvantage is it's a surgical procedure and many of the patients do not want to undergo such an invasive procedure. And even though the success rate is very high, there has been case reports where after 5 years or 10 years, there are spontaneous pain, that is dysesthesia, has been reported. So from this background, the research that has been conducted in my lab was to find out drugs or new targets for orofacial pain, or more specifically the chronic neuropathic pain. So my research was more elaborate on the drug trenilast. So this drug is a clinically proven drug and has been in used in South Korea and Japan over 40 years. So though it has been used for 4 decades traded under the name Rizaban, it has not been used for neuropathic pain. It was used for bronchial asthma, or earlier invented for the treatment of bronchial asthma along with salbutamol, and later it has been used for allergic conjunctivitis. Further, it has also proved its efficacy in treating atopic dermatitis, keloids, etc. And recently there are also studies wherein they use it for cancer treatment, or the proliferation of growth has been inhibited by the use of trenilast. So what kind of model that we have been using for these kind of research is basically it is animal research. So we use rats, more specifically the Sprague Dowley rats, SD rat we call it. So they are more specifically trained or used for behavioral assessment. And in the infraorbital nerve construction is what we give. So adjacent to the molar, we make an incision and we have the constriction model wherein we use silk sutures and we mimic the nerve constriction. So after 1 week, this model is considered to be chronic. Basic experiments, like I mentioned, that for measuring mechanical sensitivity or allodynia, we use certain equipment. So one such is the wand free. So wherein I will show you a little later and about the wand free machine. So wherein the snout of the animal is that is in the whisker pad area, we test the reaction. That is exactly the outer region wherein the surgery was conducted. Further, we also use rotor rod to check the ability or the motor skill of the animal. So basically we do a baseline reading of these tests, and one day later we perform the surgery, which I mentioned, the constriction model. And after 1 week, we have these tests which is done. And further, we inject the drugs which we are analyzing. So in my case, we use the carbamazepine, which is the gold standard as I mentioned, and also my trial drug, that is tranilast, and we have the vehicle group, that is the saline. Further, we do behavior test at different time points. So this is the test which I mentioned, that is Monfrey test. So basically this is to measure the mechanical allodynia in animals. So we place this in the whisker pad area. We use this device wherein the rat is placed inside so that only the snout is exposed. So the rats cannot see fiber tip to measure the mechanical allodynia. So we have a digital device which will give us the reading. So this is how the result will be. This is marks. Mg. We do not see any kind of difference. 75 mg, 100 hours after injection, we see that there is a difference in pain threshold. So how we report the scale is that the lesser tolerance, less, whereas in the more the number, it means they are able to tolerate the 4 hours there is relapse in pain, whereas in 100 similarly when it was compared with that of carbamazepine, as I mentioned, yes, should we continue? Ma'am, I have good internet, ma'am. I think it's okay. Yeah. Okay, ma'am, thank you. So when comparing with that of carbamazepine, which is the gold standard, we can see that the tranilast drug is as much as effective as carbamazepine. So this drug can be used. So that is what we found from the comparison of carbamazepine group. And there is relapse in pain only at 48 hours, whereas 6 hours was much efficient than compared to that of carbamazepine. So the take home is that the drug is more efficient than carbamazepine and also lasts for a longer duration when compared to that of carbamazepine. But we cannot go with this. We need to do side effects. So while using the motor coordination test, we found out that the results were much better when compared to that of carbamazepine.
Recording in progress.
They did not show any kind of lag, so it was okay. Moving on to the results of the PCR, where the trigeminal ganglion was measured, we can see that certain genes, that is AKR, SPR, those which are responsible for the downregulation of the pain, and they were seemed to in case of pain. So this is the rotor rod machine which I mentioned that where we will use for the testing the motor coordination. So it has a rod which will rotate. So we will use simultaneously the rats which are responsible for the treatment, that is the saline, tranilast or carbamazepine. And as I showed before, the results are as follows, where in 2 hours and 6 hours, we can see that there is a difference when compared to the tranilast group. So you can see that the vehicle and the drug have good response while there is a lag or less performance in the carbamazepine. So basically why we tested the BH4 or the target tetrahydrobiopterin is that it was reported to be responsible for neuropathic pain. So here after the constriction model, we use the trigeminal ganglion and do a PCR profiler array. So these are the results. We can see a heat map where we see that all the genes which were tested, specifically the SPR, AKR, QDPR, were highly expressed, and after the trenilast treatment, there is a upregulation in the genes. So when compared to that of the pain model, we can see there is a downregulation in these genes. To summarize this PCR results, we can see that after the injection of the drug trenilast, we can see that there is a response of the SPR, which is seen in the PCR. So we found out that this drug can inhibit neuropathic pain through the pathway of tetrahydrobiopterin. So it can be effectively used for neuropathic pain. So this was the first time that we proved that the drug trenilast can be used for neuropathic pain. As I mentioned, it has not been used prior, as though it was used for 40 years for other asthmatic or allergy. Now we have proposed this use for neuropathic pain. Besides this, we are also using for neuropathic pain the BONT, that is Botox, which is commonly known as the botulinum toxin. We have recently published a paper where the same bond was used for trigeminal ganglia pain, and also in this research we used it for chemotherapy induced neuralgia as well. So in this we tried it for two models. One is the similar kind wherein I showed the intraoral constriction and bond was injected. So after the injection of bond, we see that the patient injected group while compared to group. So there is a significant difference. And further, we can see that the effect lasted for about 12 days. Apart from the neuropathic pain model, we also tried this model in using where cisplatin was injection. As you all know that it causes neuropathic pain, and in this case, since it is systemically injected, we have bilateral neuropathy. That is on both the sides of the oral region, we have a neuropathic pain. Again, we confirm it using the mechanical device which I showed you before, and you can see that there is a classic difference in the pain in case where cisplatin is injected and along with bond. So that red line marks with bond. So we can see there is a effect after the bond injection, whereas only cisplatin, you see that the pain is continuous. So we continued this study for about a month and we saw a good result in the trend. Further, this is the fluorescence study where we take the tissue of trigeminal ganglion and do a cryosection, and after fluorescence staining, we see that the bond injected group showed the Alexa 488 was positive, whereas in the control wherein there was no injection of bond, we cannot see the appearance. Or even in the contralateral side, since it was bilateral neuropathic pain, we can see. Further, we also study the interleukin 10, that is the IL-10. So we have found that injection of interleukin 10 into the trigeminal ganglion can be effective. Along with, we have also seen the minocycline and the CGRP administration. Here we see that we do the cold testing and heat testing. This is for hyperalgesia. So at 37 degrees and also at 10 degrees. And the highest temperature was recorded at 45 degrees. So the extreme temperatures are exposed to the rats, and we record, and we find about the lick and face contact. That is, we give a bottle of milk and we record this ratio when they try to suck or lick the milk which is placed on a thermal rod, so that we can record how many licks or how many contacts are made, since there is a heat or a cold which is exposed to the rod. So each time they expose their mouth or the snout towards the rod, they get in contact with the heat or the cold. So if they have a neuropathic pain, we will know that are they comfortable with the exposure to heat or not, or are they comfortable with the exposure to cold, that is 10 degrees or not. So that's the purpose of this study. And further to the previous behavior testing, we do the fluorescence imaging, where it is combined and checked along with GFAP, and we can see that there is results after 1 hour of injection, and also there is a lesser positivity at 6 hours. And further to this, we also do the satellite glial culture and check about the cytokines. We usually do all the panel, that is the entire panel of cytokines, to know that which is upregulated and which is downregulated, so that we get the more specific ones, and we can gaining. A little about the IL-10 or the minocycline combination. Here we preferably chose IL-10 after the panel which I showed before. We chose the CXCL and IL-10. So after IL-10 injection, that is interleukin injection, which is directly given into the trigeminal ganglion, we saw that the pain was less in case where the IL-10 was injected. And we did the culture of the trigeminal ganglia tissue, and this is the cytokine array results. And when compared to that of the control, we found that in case of CXCL2, the day 1 expression is more, whereas in IL-10, the opposite. We see that the 14-day expression is more. So CXCL2 and IL-10 work on the opposites. So to combine the IL-10, CXCL2 along with the vehicle PBS, we have this kind of trend where we can see that the effect of IL-10 is much better when compared to that of the anti-CXCL2, whereas there is no pain or no relief from pain in case of the vehicle group. Further along with this, we also studied the minocycline combination, and it is already proved, but the combination of IL-10 and anti-CXCL2 with minocycline, that is in combination with neuropathic pain. So this has shown that for 1 hour and 6 hour, the result is same. So minocycline application to the TG can decrease the pain, and the current hypothesis from us is that it is due to the glial cell excitation, which we studied through the cell culture. So apart from this, currently we are proceeding with research where we continue about the BH4, where we study about the expression of SPR using the RNA scope assay. And we also do neural tracer marker studies to understand the transport mechanism, as in because when there is pain on one side, that is unilateral pain, it transmits to the other side. So where exactly is the connection? Of course, previously in anatomy, it is proven that the transmission is through the first order, or more specifically through the second order neuron along the thalamic tract. But we are currently trying to prove in orofacial pain, sometimes, especially in migraine headaches, we have bilateral pain. So where exactly is the transmission? We use fluorogold as a neural marker tracer. And we found, as I showed now, we know that IL-10 is effective, but we have not found the exact mechanism. So currently we are working on this mechanism. And besides this, in Japan, currently the aromatherapy is in much boom, I would say. They have special organizations where they give grants for aromatherapy related to pain or any other physiological illness. So we're also trying the aromatherapy for neuropathic pain, and we tried for several oils, and it has been very effective in lavender and other citronella oils. And besides, we're also working on the fibromyalgia models. So these are the research which I have been a part of in the orofacial pain. Thank you for your kind attention. So if there is any question, I will be happy to answer.
Request Shivakumar sir to give away some few words.
Welcome, madam. Actually, the study is very vast, right? And it's like an ocean. You have done so much of markers, pain markers, and then the drug which interactions. But finally, you say that all the drugs which you have done is only intraneural injections, right? For your central acting pains. If there is anything for peripheral acting, you have done like that.
Yeah, so the Trenilast is oral drug. So we gave an intraperitoneal injection, but for commercial use, it is available as an oral tablet. And the Botox injection was peripheral injection at the site of pain.
Other one is the malignant lesion causing the pain. Which drug you prefer for that actually, other than opioids, in malignant cases?
So currently we are trying to do, even in the case of such neuropathic malignant related pain, since no research models have been tried, we do not suggest these drugs because we have not tried in these cancer related pain or anything. All these are only injury related models or anatomically created neuropathic pain. So I think probably only after the research in those kind of models, probably we could suggest the trial of these drugs. But BONT, that is botulinum toxin, has been used and it is very effective.
Any human trials have been carried out for this Transilast till now?
Sorry, sir. Could you please repeat?
Human trials have been done in this drugs actually. Your Transilast drug, which is you see orally given, whether it's animal studies or human studies.
The drug Trenilast is actually approved in humans for oral use. So they have been used for really years as an oral drug for asthma and other allergic reactions. So it is very much used in humans. Only the neuropathic pain part is still not explored. So we have done it in the animal research and now we are continuing as a phase 2 in the human trials. I think very soon it can be given because it is already a clinically approved drug and they very commonly use this drug in Japan and South Korea for its use. We are also trying for the same in India as well.
Thank you, ma'am, for your wide explanation about the pain, physiology of pain, and then the markers and the pathways and all. And this is a basic information needed for the undergraduates as well as the postgraduates for the research aspects. Thank you.
Thank you, sir. Thank you.
Thank you so much, Swarna. You can log out. Yeah, thank you.
Thank you, ma'am.
panelist.
Sorry, I hadn't.
Dr. Vanaja Krishna Naik has completed BDS, MDS Periodontics, FHEA, MFDS RCPS Glasgow, UK, and is currently pursuing part-time PhD in the School of Dentistry, University of Leeds. She is exploring the area of psychological stress and periodontics. Ma'am was awarded T.C. White Visiting Scholarship from Royal College of Physicians and Surgeons, Glasgow, UK. In 2015, Dr. Vanja Ma'am completed vocational training equivalence, and further, she maintained her teaching at a dental hospital once a week. In September 2017, Ma'am took up her appointment at the University of Leeds, and currently she is co-leading undergraduate periodontics teaching along with pursuing her research in psychological stress and periodontal disease. She maintains her clinical treatment sessions once a week. Dr. Vanaja Ma'am is also a member, Committee of Periodontal Research Group, part of British Society of Oral and Dental Research Society, representing early career research groups. Ma'am's research interests are psychological stress and periodontal disease, mechanistic links between diabetes and periodontics, mucogingival surgical procedures, and regenerative periodontics. We welcome you, ma'am.
Thank you so much. Can you all hear me?
Yes, ma'am.
Brilliant. It's a pleasure to be in Savita again, and it's becoming part of the tradition every year, and I enjoy it. Basically, when I was told that one of the theme of the research was pain, I started wondering how pain research has evolved in periodontology. So today's topic is about evolution of pain research in periodontology, or in the discipline of periodontics. Sorry, it's kind of, yeah, here. So I'm based at Leeds, which is a part of West Yorkshire in Northern England. And as David Hockney, one of the painter and photographer from West Yorkshire, says, it is quite dramatic and beautiful, the cracks and things. And I do get to see some amazing scenery around me. Only downside, now we are in deep winter, going through some snowing as well. So with that, let's start now. So the objectives and scope of this lecture today is about pain research in periodontics over the years. And let's just discuss what are the different domains of pain research in the field of periodontics, and what different pain assessment techniques have been used, and evolution of pain assessment in periodontics and pain control. So what is the definition of pain? If we have to look at the International Association for the Study of Pain, it defines pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. However, your unpleasantness doesn't mean or doesn't translate to severe pain. So the argument was there should be an alternative definition. they suggested that a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. So, what is our primary biological purpose of pain? Is it good or bad? It is definitely good, and it serves as a protective mechanism for an individual, and it is a warning sign of something. So, one can address that problem and one can do something about it. So, if we have to look at the categories of pain, it could be somatic, psychogenic, and neuropathic. And this is a very broad category, what I'm suggesting here. And perhaps the pain related to gingiva or periodontium comes under somatic pain. Now, if we have to discuss anything related to periodontal diseases, we have to kind of go back to the classification of periodontal diseases framework of 2018. And if we look at this, can we say all periodontal diseases and conditions are painful? Now, gingivitis and periodontitis, unfortunately, they are not. They are not painful conditions until later stages. Whereas your necrotizing periodontal diseases or periodontal abscesses, they can be painful and they are acute in nature. So what it kind of makes us think is there are two different manifestations in the same tissues, and we don't have protective mechanism for one of the type of disease, which is a very common cause for tooth loss. Now, gingivitis and periodontitis both are inflammatory, chronic inflammatory type of diseases. Now, if we look at the cardinal signs of inflammation in general, which are tumor, rubor, calor, dolor, and functionalacia. All of this, if we kind of translate to our gingivitis and periodontitis environment, we have certain clinical manifestations. Except pain, there should be stimulation of nociceptors. However, we don't get to see pain, or we don't come across pain as frequently as we should. So some of the earlier research have suggested the prevalence of pain reports in periodontitis patients is only about 6.2%. However, the recent longitudinal study from our colleagues in Birmingham, they suggested that the odds of reporting pain in a worst periodontal health category were 1.9 times higher than in the best periodontal health category. So it is not entirely painless. They do, or we do come across some pain manifestations in patients, but it is too late, at that stage to do anything, or, to kind of give them the assurance that they would retain most of their teeth. So if we have to think about nociceptions in periodontal patients, the first primary question what comes to mind is there a pain producing environment at all in periodontitis? Yes, certainly. Yes, there is hyperalgesic factors release due to bacterial and host microbial interaction. And these can release lipopolysaccharides or the virulence factors of the microbial or microbes can kind of present as PAMPs or pathogen associated molecular patterns to stimulate the expression of the pattern recognition receptors such as toll-like receptors and TLR4 or TLR2 depending on which microorganisms PAMP it is. And thereby there is a release of pro-inflammatory cytokines and then hyperalgesic factors. However, what is the current challenge is there is a lack of extensive characterization of overall innervation of human periodontal tissues under inflammatory conditions. So we don't know what is their morphology or phenotype in periodontal diseases. The possible reason could be altered innervation in the periodontium, altered sensory perception due to shift in the density of innervation due to infection-dependent changes in local nerve growth factor concentration, and phenotypic changes of periodontal neuronal population. So if we look at these two schematic diagrams, definitely, there is a whole lot of things going on, and there is a upregulation of pro-inflammatory and hyperalgesic host mediators, which kind of releases all these pain-producing mediators. So there should be definitely release of those mediators manifesting into pain. However, possibility is there is also downregulation of pro-inflammatory hyperalgesic host mediators due to release of other factors such as your interleukin 10 or PIMPs, which are basically anti-inflammatory in nature. So there is a possibility of suppression of inflammation and inflammation-dependent nociceptor sensitization by cleaving interleukin 6 by certain virulence factors such as gingipains from keystone pathogens such as Porphyromonas gingivalis. There is a possibility of release of endogenous opioids, and the butyric acid, which is a metabolic byproduct of bacteria, possibly it is stimulating cell apoptosis and neurite retraction in a neuronal cell line. Thus, it possibly changes periodontal innervation in periodontal disease. Or there could be elevated levels of endogenous analgesic mediators and or their receptors. And as I said earlier, there is a suppression of pro-inflammatory mediators and upregulation of anti-inflammatory mediators. So these are possible mechanisms which are kind of explored in different study designs to explain why periodontitis, or earlier we used to call it as chronic periodontitis, could be painless. So the future direction in exploring anti-nociception could be, inflammatory and nociceptive processes around in periodontitis environment, microenvironment, and in acute human periodontal conditions, such as in necrotizing periodontal diseases. One should wonder why there is a pain in necrotizing periodontal diseases situation. Possibly because there is release of acute inflammatory mediators such as bradykinin, histamine. Probably that is the reason why there is a pain-producing situation. These are all speculations what we are doing at the moment. We don't have sufficient information and they are not sufficiently investigated. Further, whatever evidence we have so far, they are coming from the studies that focus either on the aspects of the periodontal disease or on the pain in tissues which are outside the mouth. So it cannot be translated directly to a periodontitis situation. So when I started looking at pain and periodontics in a search engine, it basically gave me a hit of over 3,800 results. And the literature starts from 1950s and it comes up till to date. And you can see a slow increase in the evidence or amount of evidence what we have out there. So we have kind of discussed that periodontitis is most often it is painless. So where is this pain research kind of booming? Where is it booming from? So what are the different sources of pain in periodontics discipline? It could be at later stages of periodontitis, in acute periodontal disorders such as necrotizing periodontal diseases or abscesses, or during periodontal probing, pain during LA administration, but this is not just limited to periodontics discipline, but this has been explored elsewhere as well. Then we have non-surgical periodontal treatment, which we currently call as professional mechanical plaque removal. So in that area, a lot has been explored as well. And then surgical periodontal therapies and post-operative pain control as well. So the different sources of pain in periodontics discipline are this list, and based on this, we see a surge of literature over the years. So when I filtered only case reports or case series, over 200 articles starting from 1960s in PubMed search engine kind of gave me this graph. And it mainly talks about the acute periodontal disorders. Most of the literature is based on acute periodontal disorders, such as necrotizing periodontal disorders or abscesses. And this possibly provides us the wealth of information for us to kind of generate future hypotheses for further research. And It gives an explanation about pain assessment in these case reports, but they are mainly dichotomous, pain present or not, rather than actually going in detail. Obviously, when a patient presents with pain in a clinic, our focus is to kind of relieve the patient of the pain, rather than kind of probably subjecting them to go through certain pain assessment techniques. And most of these case reports talk about management of patients or management of these emergency situations. Further, when I looked at the filter of observational studies, only few studies came up, and the disadvantages of observational studies are they do not always control for confounding factors. Risk of bias can be high. There is Hawthorne effect, which is basically if somebody is observing, there is a different type of response you would get. And these are useful useful research strategies whenever a clinical trial is not feasible or possible. The most of periodontal literature on pain and periodontics is of controlled clinical trials, or basically clinical trials. So there were over 500 results in PubMed search engine, and the studies kind of range from testing different LA techniques to instruments, non-surgical and surgical techniques, periodontal packs, and they all have seen the subjective pain experience during these different domains. Further now, recently, it has been encouraged that, in any clinical trials, include patient-reported outcome measures. So if you are doing a clinical trial to test two different techniques, look at, not just the clinical endpoints, such as, probing pocket depth or, healing index or whatever, which, traditionally we kind of look at. It is better to include patient-reported outcome measures as well, such as the perception of pain. So you can see in recent literature where the patient-reported outcomes have been kind of reported. And the popular pain assessment tool in most of these studies are visual analog scale or numerical rating scale or verbal rating scale, and not all controlled clinical trials were randomized. The other type of evidence, which is kind of towards the top of the pyramid, is systematic reviews, and there around 140 results came up. And the advantages of these type of research is there is a systematic search of the published literature and the risk of bias assessment, and can make sense of pool of data through quality analysis. The top of the pyramid is meta-analysis, and there are over 60 results, and basically these type of analysis gives us a robust statistical integration of body of data, what is published, and it improves the precision to estimate the effect size, and it kind of derives credible and reliable conclusions in the end. Now, the highest form of evidence, what we are currently using is S3 clinical guidelines, which is not just the meta-analysis, but it kind of includes a panel and the patient input as well. So those are coming up as well. So there is a whole lot of different type of literature what we are going to kind of witness. Now, pain assessment tool. So once we have kind of agreed that there are painful conditions as well in periodontics discipline, we need to kind of look at what are the different pain assessment tools. As we said earlier, pain is internal, very private experience, and it is very subjective. So basically, a self-report is a gold standard pain assessment technique. Ideally, a pain assessment should address multiple domains, not just sensory and affective, which is like pain intensity or pleasantness. It should also include the temporal dimensions, such as time frame, whether it is episodic or continuous or character of pain. So generally on clinics, we use a format of Socrates, which is site, origin, character, whether it radiates, association with any other symptoms, any temporal dimension such as time frame, and exacerbating and relieving factors, and severity of the disease. So probably that kind of captures, but in most of the pain research, we tend to see only the pain intensity being captured. There are different tools to assess pain in form of inventories or scales to capture, however, to capture all dimensions of pain, we probably need a multiple items in a questionnaire, such as McGill pain questionnaire. Otherwise, it's mostly numerical rating scale, visual analog scale, verbal rating scale, Likert scales. Those can be used as well, or those have been used in the literature. And then further, there is exploration in the objective pain assessment techniques, such as quantitative sensory testing as well. Now, commonly used scales in periodontal research has been visual analog scale, numerical rating scale, verbal rating scale, faces pain scale revised. So there is a significant correlation among all of these scales. However, the numerical rating scale, which ranges from 0 to 10, is most accepted by adults. Patients prefer to describe pain rather than number them. So we need to be mindful. And I think, most of our research probably is focused on the numbered research, or, basically the visual analog scales or scale related pain assessments. And most of the literature suggests that children and elderly prefer FPS or scale. Another thing what has been highlighted is the discrepancies between VRS, that is verbal rating scale, and VAS exist. The reason is VAS scale is a horizontal line, which is 0 to 100 millimeters, and it's a plain line, measured line, and you ask the patient to kind of mark their pain, or where they feel there is a between these 2 points, no pain and worst pain, and they should be able to tell you where it is or mark, and then it is measured. Whereas if you see the verbal rating scale, it is no pain, mild, discomfort, afflictive, horrible, and torturing. So the VAS is far more sensitive and in kind of differentiating the pain shift, whereas the verbal rating scale does not do that. So the data between the verbal rating scale and visual analog scale are not the same, and they cannot be interchanged. And most of the literature, if you see, sometimes they say that we have used visual analog scale, and perhaps they have just used the verbal rating scale. So if we have to look at the strengths and weaknesses of VAS and VRS, both are rapid. However, the sensitivity is higher in visual analog scale. There is good construct validity in visual analog scale, and data type with visual analog scale we get quantitative, and verbal rating scale is mostly ordinal. And conceptually, VAS is complex and VRS is probably relatively easy to score, and VAS can be, prone for inaccuracy, basically because if you keep xeroxing, or, you keep taking the Xerox of the copy, the line tends to get longer, and then there is a wrong estimation of the pain. And the compliance of respondents is low with VAS compared to verbal rating scale. The objective pain assessment, if we look at it, the most direct method is recording the neural activity, which is directly from the peripheral nerves, and it is known as microneurography, and may be useful for patients where there is a difficulty in communication or in special care patients. Further, objective pain assessment can be done using your fMRI imagings or electroencephalographic rhythm, and single unit and local field potential recordings in anesthetized animals. So these are the different objective pain assessment techniques have been used in the literature. Now coming to acute periodontal lesion domain of the pain research in periodontics, as I said repeatedly, mainly periodontal abscesses and NPDs, and sometimes desquamated gingivitis has been explored. And obviously, the acute periodontal lesions are rapidly destructive and painful lesions. And most of the literature are case reports, are studies, and sometimes there are some descriptive studies or microbiological studies comparing the efficacy of antibiotics in these kind of situations. And most of the literature again have gone for pain intensity and duration using some sort of scale. And sometimes they have just said whether it is pain present or not, rather than describing on any subjective scales or any objective measurements. Now, another domain is pain and periodontal probing. So if we look at the literature, there is a surge of literature from 1989 onwards, and it has peaked in 2020 and 2021. Now, periodontal probing, although it seems to be very simplistic examination, it can cause discomfort and pain, and we must respect everyone's pain experience. It's very subjective. What one can perceive as pain, the other may say it is easy, they didn't feel anything. And to this end, there are several attempts to reduce the discomfort or pain by using intrapocket topical anesthesia. Different probes have been tested to see the pain during probing. And it has been reported that peri-implant probing is far more painful compared to periodontal probing. One of the developments in the objective assessment of pain during probing is the use of ECG and PPG, that is electrocardiography, photoplethysmographic signals, which are captured during probing event by a chairside digital push indicator during the event of pain. So this machine learning or artificial intelligence kind of is creeping in to possibly, make things better and to capture every brief instances of pain which is experienced by the patients and which are not covered by the established indicators. Now, another domain of pain is post-operative pain on periodontal clinics. And if we look at the classification of post-operative complications, there are different grades. And our post-operative pain of periodontal procedures can fit into two categories, that is grade 1 and grade 3. Dentinal hypersensitivity sits with grade 1, which is a localized complication accompanied by no adverse effects on the success of the surgery and or procedure in this instance. And severe pain, which is grade 3, which is localized or systemic complication that impairs patient's daily activity but does not require hospitalization. And most of these are again assessed using visual analog scales or Heft-Parker verbal rating scales, which kind of includes a bit of qualitative information there. And the severe pain has been assessed using visual analog scale and based on the number of analgesics. Professional mechanical plaque removal, which is the current terminology for root surface debridement or root planing in the olden days. So that can be painful, or some patients cope absolutely fine and they say specifically we don't need any kind of local anesthesia, I can undergo this procedure without any local anesthetic. However, there has been some developments in using the virtual reality to see if it is effective in pain management during PMPR. So two studies in 2009 and 2019, they both used immersive virtual reality. And you can see, if you remember Big Bang Theory, Sheldon Cooper using virtual reality, it was quite funny, but I think that could be adapted in clinical environments, and that could possibly help in reducing the pain during PMPR for patients who experience pain with these procedures. My only criticism for this domain is a lot of these studies didn't include anxious patients, because the value of this distraction technique probably is for extremely anxious patients who suffer from debilitating anxiety. So probably in future, these distraction method can be used in highly anxious patients for pain control during PMPR. And one of the systematic review has looked at the topical intrapocket anesthesia for pain control during PMPR. and they kind of concluded saying injectable anesthetic is preferable over topical intrapocket anesthesia for instrumentation. However, if a person is extremely anxious and doesn't like the sight of needles, um, injectable anesthetic doesn't kind of do much, and it is a major turn off. In those kind of instances, probably topical intrapocket anesthesia as a starting point does have some value. Now, pain and periodontal flap surgery gave me this kind of a graph. Again, you can see 2022, 2023 has given more number of studies, almost close to 35 per year. And pain and periodontal regeneration, again, you can see it is slowly growing, and there are developments in that area. So in periodontal regeneration, there are majority of the studies have used visual analog scale again to assess the intraoperative and postoperative pain. There is a suggestion of use of magnification or magnifying loops, or surgical, the microsurgical or using microscopes would be beneficial in controlling pain, or in reducing the postoperative pain. There is a surge and advent of these minimal invasive surgical techniques in the last couple of decades. So a recent systematic review has suggested minimal invasiveness for the treatment of osseous defects. A single flap approach, that is elevate just either buccal or lingual or palatal flap, based on the defect configuration, obviously, to regenerate rather than exposing on both sides, that is both buccal and lingual flaps, which is traditionally what we used to do. So the post-operative experience is comparatively less when they have used a single flap approach, that is raising a flap on one of the one side, that is either buccal or palatal. Further, the adjunctive use of membrane, that is GTR membrane, was significantly associated with higher post-operative pain experience. This could be because of the operator's experience, and also the procedure itself. It is technique sensitive. It is going to take longer time, and that could contribute to the post-operative pain experience. Further, if we look at mucogingival surgical procedures, there are several literature out there. The most important one perhaps is the pain at the donor site in procedures like free gingival graft or connective tissue graft, where you would use a collagen sponge or suture, or palatal stent or cyanoacrylate plaque and pack, and they have kind of compared these three different strategies, and they have seen palatal stent works better. So I think these are very well-informed clinical decisions which we can make based on these literatures. Use of lasers on post-operative pain control. They have suggested the photobiomodulation therapy using diode could reduce the intraoperative or post-operative pain compared to conventional periodontal therapy. Further, erbium YAG lasers compared to conventional instrumentation have been suggested to suppress post-operative pain. Apologies for spelling mistake there. And this was pretty interesting because they chose to use the word as suppression rather than reduction in the pain. That was pretty interesting. And they all have used the visual analogs course. And in the end, one of the systematic reviews has suggested that there is insufficient evidence to suggest that lasers help in reducing post-operative pain control, and there were substantial methodological weaknesses in the available studies to make that kind of a conclusion. So more well-controlled RCTs are essential to kind of derive that kind of meaningful conclusion. Pain control following dental implant placement. Periodontics discipline is not complete without kind of including dental implant placement. So again, they have used different type of analgesics for post-operative pain control. In summary, periodontitis is generally, obviously, painless. The responsibility lies with a member of the dental team to kind of pick up this disease and inform the patient. And any history of pain, we follow a Socrates format, and further clinical examination and special test kind of gives us the overall picture to rightly identify or diagnose the disease or condition. Pain experience during periodontal examination or procedure influences the dental attendance pattern. So why should we need all these, or why should we look at the pain research? Because it kind of gives us more information and probably inform us better how to kind of look after our patients well. Because if the patients feel pain on dental chair, they might not come back, and that's the downside. Majority of evidence is still based on fewer qualitative research. Having said that, I have to be totally honest, I did not come across any kind of qualitative research in pain and periodontics field. So I think it is important that some qualitative research should be undertaken to understand the patient's or subject perception of the situation. Mechanism of pain manifestations are still very much unclear, understudied, and there is a future need to kind of chase that. Lack of clarity over pain assessment because we are just using mostly unidimensional pain assessment. And it's good that we have the emerging patient-reported outcome measures in clinical trials. It is also essential for us to kind of note the individual differences and personality differences in periodontal pain research, which has not been done so far. And again, if we need to kind of look at race, ethnicity, and cultural differences when we do a pain research. And there is an advent of minimal invasive strategies, which is fantastic because that helps in post-operative pain control. For future direction would be qualitative research in each culture, because culturally also pain gets influenced, or pain perception gets influenced. More pragmatic studies, because most of the studies are done in hospital settings, not necessarily all pain are presented in hospital settings. So I think more pragmatic studies should be encouraged. And data collection, again, not just the visual analog scale. I mean, it is doing its job, but probably, in the innovation in those directions, probably we can kind of capture the minute nuances, what could be there, and which could inform us to manage our patients better on clinics. Thank you for listening, and I would like to acknowledge some meaningful discussions with Professor Ian Chappell at Birmingham and Professor Philip Brayshaw at Dundee, and Dr. Aradhna Tagnet, who is my colleague. Thank you very much.
Thank you so much, ma'am. We have in our session, we have a moderator here, Professor Dr. G. Shivakumar sir is here. So he will conclude the session.
Thank you for your presentation. And its whole lesions of the periodontal aspects has been covered, where all the pain, common man pain, has been sensed out in this presentation. I would like to have one small request. Is there is any studies related to the gingival clavicular fluid analyzing the pain?
Yes, I think, that's an interesting question what you're raising. And I did come across, there are plenty of interleukin 6 and, interleukin 1 beta or TNF alpha. They have kind of looked at, indicating biomarker for pain. However, the argument here is they are biomarker, biological markers, which are kind of translating to pain experience, subjective pain experience. And these are more of neural elements, and the ideal biomarker should be at neural activity level, if that makes sense. So there are plenty of studies which have examined to look at and correlate the subjective pain experience with the inflammatory biomarkers. I hope that answers your question.
Yeah, thank you, ma'am. But collection of GCF is a little bit difficult, I feel so, for the study. Is there any easy way to take that out?
Sorry, I can't hear you properly.
No,
Can
the
somebody...
collection of gingival clavicular fluid is a little bit difficult. I knows that for your study. Gingival clavicular fluid collection. Is there any way of novel way to collect it.
To collect the GCF.
Yes, yes.
So normally we use here the paper strips. So that's the way is the collection. Is that what you're asking?
Yes, madam. Yes, that's right. Is there any?
Yeah. So normally we use the paper strips for collection of the GCF.
Okay. Thank you, madam. Thank you for the presentation.
Thank you so much, ma'am. It was a very insightful presentation, a very new perspective. We really enjoyed watching your presentation. Thank you so much, ma'am.
Thank you.
Yeah, thank you.
Thank you so much.
Thank you. Our next session for the day is Alumni Showcase. We have two very illustrious alumni waiting to showcase their cases. I invite Dr. Suganya to take over.
Good afternoon, everyone. I'm super proud and happy to introduce our next keynote speaker, our alumni, Dr. Krishnapriya Umashankar. She is very much passionate about the subject and doing great in her career. She completed her master's in 2021 and she was the academic topper as well. She published her research works in various national and international journals. She completed fellowship in head and neck pathology at Malabar Cancer Institute and currently working as an assistant professor in the same institute. I welcome Dr. Krishnapriya to deliver her note speak.
Good afternoon. Thank you, Sukanya ma'am, for the wonderful introduction. It feels very prestigious and I feel very privileged to stand in my alma mater, Savita Dental College and Hospitals. I thank Deepak Nalasamy sir and Viren sir for giving me this opportunity. I'd also like to thank Dr. Pratibha ma'am for molding me into whoever I am today. And I'm forever grateful for this institute and I'm always proud to be a pathologist. So I'll be presenting a case. It's a very interesting one. This is a firstborn female baby who was born for a non-consanguineous parentage by LSCS delivery. the baby presented with an intraoral swelling in the right side of the floor, which was also seen extending to the mouth and crossing the midline. However, it was not very extending into the other side of the oral cavity also. So on our examination, it was a 3.5 into 3 centimeter swelling, which is seen in the right side floor of the mouth involving the tongue. And the parent also complained of difficulty in feeding the child. So an MRI was done which actually demonstrated a T2 hyperintense and T1 hyperintense lesion, which measured 5 into 3 into 4 centimeter, which was seen involving the right side of the floor of the mouth with extension into the sublingual space and the right submandibular gland. It was also seen extending posteriorly up to the right tonsil. So the differential diagnosis by the radiologist given was a possible mesenchymal neoplasm, possibly a sarcoma, but they were not able to identify the actual histiogenesis of the tumor. So we received a second opinion biopsy. This biopsy, it was not a biopsy, it was actually the excision of the entire lesion. This was done outside at another hospital, and at MCC, at Malabar Cancer Center, we received this slides for review. And in scanner, that is 2x and 4x, we were able to appreciate a poorly circumscribed neoplasm, which actually had a heterologous component of a cartilage formation, as well as the surrounding neoplastic cells, which were arranged predominantly as sheets and also as streaming fascicles. And in 10x, we were able to appreciate streaming fascicles of spindle cells, which were not very atypical, but a kind of atypical. And we were also able to see metaplastic cartilaginous formations. However, this cartilage was not neoplastic per se. So in 10x, we can also appreciate dilated blood vessels, and we were also able to appreciate spindle cells. And in a 40x magnification, we were able to appreciate very nice plump spindle cells, which did not have a conspicuous cell boundaries. It had a round to oval hyperchromatic nuclei. The chromatin was characteristically granular, but nucleoli was not prominent. And taking a closer look at the cartilage actually had a normal cartilage appearance. It had a condensed nuclei, and there were chondrocytes which were placed within the lacunae. But the cartilaginous cells were not atypical or neoplastic per se. So we were also able to appreciate mitosis 2 per hyperfield field. So for 10 hyperfield field, it was around 16 to 20. So with this, the possible differentials considered at this point of time was an extraskeletal mesenchymal chondrosarcoma, well-differentiated type, a malignant peripheral nerve sheath tumor with extensive cartilage formation, a rhabdomyosarcoma, spindle cell rhabdomyosarcoma with extensive cartilage formation, and a monophasic synovial sarcoma with cartilage formation. So we proceeded with a panel of IHC markers, and to our surprise, we found it was positive for CD99, which was a strong membranous positivity. TLE1, which is the characteristic marker for synovial sarcoma, was also positive, nuclear staining. BCL2 showed a characteristic membranous staining. CK was focally positive, which was cytoplasmic and membranous. S100 was nuclear and cytoplasmic positivity in focal area. And NKX 3.1, which is now considered to be the marker for extraskeletal mesenchymal chondrosarcoma, was also found to be negative. So the differentials that were considered and the IHC, based on the IHC possibility, the more favored diagnosis was synovial sarcoma because CD99, TLE1, CK, BCL2 was positive with focal S100 positivity. Since NKX 3.1 was negative, extraskeletal mesenchymal chondrosarcoma was ruled out. MPNST was ruled out. Despite having an S100 positivity, MPNST did not show a SOX10 positivity. And RMS was ruled out because Nesmin and myogenin were negative. So the final diagnosis, what we released was an intermediate grade sarcoma because mitosis was less than 9 to 19. Necrosis was not present, and the differentiation grade was 2. So final diagnosis as per FNLC LCC grading was intermediate grade sarcoma. A monophasic synovial sarcoma with extensive chondrite differentiation was favored, and we advised an SS18 SSSX fusion transcript molecular study. And we found that FISH was negative for SSA18, SSSX 1 and 2. So in our center, we have probes only for SSSX 1 and 2. Synovial sarcomas also show fusion transcript of SSA18, SSSX 4, and also HEY-CoA1 translocation is also seen. So this case was negative for SSSX translocation. So, as per the condition of the patient, the baby received 7 cycles of chemotherapy, but unfortunately, the baby passed away due to pneumonia and ARDS 7 months following the treatment. But during the time of death, the baby did not have any residual disease. So, moving on to discussion. Pediatric soft tissue sarcomas are actually a heterogeneous group of malignant tumors that are believed to be originating from a primitive mesenchymal tissue. It accounts for 7 to 8% of all the childhood tumors, and congenital sarcomas are even more rarer, which accounts for only 0.05%. Synovial sarcoma was initially identified by Simon in the year 1865. However, the term synovial sarcoma was not coined by him. He found out a similarity of these neoplastic cells to be very synonymous with the synovial membrane cells. But still, he didn't coin the term synovial sarcoma. He felt something was different. Later, in 1954, Jernstrom was the first person who actually identified a head and neck synovial sarcoma, especially in the TMJ part and also in the pharynx, and he found out that he gave the term as synovial sarcoma. Later, following the studies, it was found that synovial sarcoma does not or not necessarily mean tumor arising from the synovium or the synovial cells. It's just a misnomer, and these group of tumors is now categorized as soft tissue tumors with undifferentiated malignant potential. That is, we are not able to identify what exactly is the histiogenesis of this tumor. So synovial sarcomas in head and neck accounts for 5 to 7%. So these, as per the recent WHO, it is categorized into monophasic or spindle cell synovial sarcoma, biphasic synovial sarcoma, which has an epithelial and a mesenchymal component, and a poorly differentiated synovial sarcoma. The most common site is extremity, that is 75 to 85%, followed by trunk, which accounts for 15 to 20%, and head and neck 5 to 7%. Most in head and neck, the most common site is the retropharyngeal and the parapharyngeal spaces, and in oral cavity, the most common site is mandible, followed by the tongue. And imaging wise, as per Enzinger, 15 to 20% of the cases show radiopacities and with focal calcification and ossification. So the radiological differential diagnosis for a synovial sarcoma with radiopacities include an extraskeletal mesenchymal chondrosarcoma as well as an osteosarcoma. So histopathologically, just rushing through, biphasic, as the name indicates, it has two components. The epithelial component can be arranged as glandular pattern, cords or nests. Since it's epithelial, it's always cytokeratin positive, and it also has a spindle cell component, which is the plum spindle shapes with hyperchromatic nuclei and a granular chromatin. So these take up the other marker positivity. Monophasic or spindle shaped spindle cell synovial sarcomas have extensive sheets of only spindle cells, and the characteristic feature of a spindle cell synovial sarcoma is that it can take up two other morphology. One is a fibrosarcoma, which shows a herringbone pattern of an arrangement of the spindle shaped cells, that is one. And also, solitary fibrous tumor is another differential diagnosis, because also hemangiopericytoma, which shows stragon pattern of vessels, which is seen in 1/3 of the cases. And the third type is a poorly differentiated carcinoma. Poorly differentiated carcinomas of synovial or synovial sarcomas, they actually take up a round cell morphology. Mostly it overlaps with the sick or beak or rearranged sarcomas and also Ewing sarcoma. But the more interesting feature is that this is the only type of sarcoma which shows necrosis, increased mitosis, and more nuclear pleomorphism than a biphasic or a monophasic synovial sarcoma. Also, presence of mast cells are seen, which can be illustrated or demonstrated using toluidine blue. Calcification with or without ossification and extensive metaplastic cartilage formation is seen in 15 to 30% of the cases reported in synovial sarcoma. So immunohistochemically, cytokeratins are the ones that are readily available in all the labs, but EMA has more specificity and sensitivity. So EMA is more positive than cytokeratins, followed by BCL2, CD99, which will always show strong, moderate membranous positivity like Ewing sarcoma. But the added one is the transducer-like enhancer protein, that is TLE1. So TLE1, it is not very specific. Specificity is only 75 to 80%, but sensitivity accounts for 85 to 94%. The other tumors which can show TLE positivity are fibrosarcoma and MPNST. Focal S100 positivity is also seen in cases with synovial sarcoma, especially monophasic one. Alpha smooth muscle actin can also show 50% positivity. And there are two new recently developed antibodies. One is SS18 SSS6 fusion specific antibody, which is reactive against the specific breakpoint. Another one is an SSS6 specific antibody, which is reactive against the SSXC terminus. This has a higher sensitivity as well as a very characteristic specificity, that is 95 to 96%. Although these antibodies are not readily, it is available, but not as readily available as the other antibodies. And the diagnostic molecular pathology is demonstration of SS18, SSS6 1 to 4 fusion using FISH or other cytogenetic methods. So just going through the literature of all these synovial sarcomas that have been reported from 1971 to 2023, we were able to identify 18 cases of synovial sarcoma in the oral cavity specifically, of which the youngest age group was of 11 years of age. Males being more commonly affected than females. The most common site in the oral cavity includes tongue, followed by mandible, maxilla, and only one case has been reported in tonsil. Histological subtype, monophasic synovial sarcoma was more common in head and neck than biphasic synovial sarcoma. And there was one case of monophasic synovial sarcoma which was mimicking osteosarcoma that was seen in the tongue. And 74 cases in the head and neck only showed SS18, SSSX fusion. And no cases in the oral cavity showed metaplastic cartilaginous formation. However, we were able to identify a single case report of a 34-year-old female who showed FISH negativity for SS18 SSSX fusion. She had a similar morphological characteristic of monophasic synovial sarcoma with an extensive cartilage formation. And but this patient showed a HA1 NCOA2 fusion transcript by RT-PCR method. So thus to conclude, this case is being presented for its rarity because of the age, considering the age as well as the management, the patient, and this has been presented for its rarity and successful management, and also to alert all the pediatricians that not all the swellings in the congenital or the neonatal period are benign. Early diagnosis and effective treatment is vital for improving outcomes in neonates with malignant tumors. So these are my references. Thank you. I would also like to extend my thank you to Malabar Cancer Center, Dr. Sangeeta K. Nayanar, Dr. Vivek Nair, and Dr. Anand Vijay Narayanan for actually supporting and helping me out with this. Thank you.
Thank you, Dr. Krishnapriya. It was a wonderful lecture. Now I request Dr. Simranjit sir to felicitate Dr. Krishnapriya. I'm cherished to welcome our next energetic alumni, Dr. Dinesh. He completed his master's in 2023. His achievements during PG includes consistent PG Performer Award, PG with highest number of publications in the 2 consecutive years. He published more than 25 papers in various national and international journals. He also has 3 patents and attended various workshops in molecular biology and forensic odontology. He is currently working as a research associate in Jawaharlal Institute of Postgraduate Medical Education and Research in the Department of Surgical Gastroenterology in a project creating artificial intelligence-based treatment planning 3D image-based softwares for patients with liver cancer and other liver diseases. I am glad to welcome Dr. Dinesh.
Thank you very much for the warm welcome, ma'am. And thank you once again for the organizing committee for calling me here back to my home, parent home. I have learnt a lot of things from here. including the place which I am right now is artificial intelligence in healthcare, which was a small thing is to start with. It was a small project which was given to me by Dr. Karthikeyan sir. Using the oral clinical images, I started my journey there, and I published an article there too. Now I have got an opportunity in a prestigious JIPMA institution in ICMR funded project. To start with, this is not actually a proper presentation of a lot of a proper introduction, conclusion, or a lot of stuffs. This is just a fact or a few important facts to be known as a basic BDS or an MDS to go on a different scope of approach towards a research in AI for healthcare. Since it's the current trend now, I have also been started my journey there for like past 6 months. Currently, for the past 2 months, I'm working day in and day out in AI. So I thought it will be a nice thing to share some insights about that to my juniors. So the top trends in AI in healthcare is like health analytics, the diagnostics, which is our core, and telehealth like chatbots, the medical robots, in the hospital management, the clinical decision support, the clinical trials, the public health management, cybersecurity, and personalized healthcare. As of now, there are about 3,103 startups in the worldwide it has been available, of which the healthcare analytics, which is like the data analysis, has been the priority, followed by the diagnostics, and followed by the telehealth, which is like the chatbots. And in the spread of the worldwide, the US is being the dominant in the area, followed by the other countries, and UK and India is coming in the back. To not in detail, just to shower in the every part of the AI, it's starting with the healthcare analytics by the every single data from the our wristband of like Fitband, our phone, pedometer, every single thing, our documented files, X-rays, radiographs, even the electronic health records collect some of the other data, which is being analyzed by the artificial intelligence. The softwares are developed for those, and it further recommends the few recommendations of medications or the follow-up or everything to the both the practitioner and the patient for good quality of life. So these are the areas of artificial intelligence into research currently, of which the healthcare operations dominates, followed by the big data analysis in the finance. Everything comes later only. The decision support or the treatment plan to be done, or the diagnosis, the decision support in the accurate diagnosis, or the which further diagnostics to be done is being supported by the artificial intelligence. Where the public health management, the public health surveillance, is recently in COVID-19, the AI played a very huge role in tracing the primary patient or tracing the community who is being affected, or any other pandemic epidemic to be coming in upfront. AI is going to play a huge role. And in image processing and analysis, the radiology, histopathology, which is our area of interest in oral pathology diagnosis or cancer diagnosis, image identification using the object identification software and everything else is coming under it, and it is being playing a huge role on it. Based on the clinical specialty, oncology is being the primary area of interest for research, followed by the cardiology using the fit bands, and everything else comes later on. In the AI algorithm models, deep learning model, which is like a self-learning model, is being in the uptrend, followed by the support learning model and other things. I'm not going to bore more about it. Next comes the medical image diagnosis, like ultrasound or MRI or a CT, histopathology. Everything comes under medical image diagnosis, where individual features or the individual cellular features, morphological features, the radiology with the radio intensity or lucency, everything comes under, and we can train the algorithm for the accuracy in patient prediction of the lesions. So, of which, based on a study, MRI and the microscopy, and followed by CT, are the more commonly used for the research purposes in the head and neck pathology and other pathologies. So this is like for an example, a radiograph is being given to a software, a CT, MRI, or anything else, which is a trained software is being available, and we can introduce the CT or MRI of newer patients, and it can detect the lesions of sight. So it's similarly for the ophthalmology, pathology, and dermatology, the clinical images of previous patients with the accurate diagnosis or any skilled pathologist will be training the software, and further, even after the series of several training, it can diagnose the lesions. So there are three types of learning, which is supervised learning, unsupervised learning, and reinforced learning. Supervised learning is like we are training the algorithm by tracing out the normal and the pathological site, like dysplastic cell and the normal cell and everything else, like keratin pearls and the non-normal adipose tissue and everything. Those are like supervised learning. We will be training. In the unsupervised learning, it will be like heterogeneous data. The number of every single cancer case we receive like that, each patient will be different, and each patient quality of life will be different, each patient prognosis will be different. The algorithm itself will learn from the prognosis, the duration of survival, everything it will learn by itself. And reinforced learning is like it will give a recommendation, and if we reinforce that this is not the actual thing, it will correct by itself, and furthermore it will be developing itself. And the telehealth is like the chatbots which is being available right now. There is a single chatbot available for dental too, which will be dealing later, where these M-Health software devices, everything will collect the data and will be sent to the artificial intelligence expert, and it will be reverted back like drink water, have some more walk, everything will be recommended in the futures. Even it's right now. And medical robots, these are like the classification of either the autonomical progress of the medical robots to handle by itself, or with the assistance, or for the surgical purpose, rehabilitation, patient follow-up, for a longer term or a shorter term, with a mobile based virtual mode, or a both virtual and a hardware mode, physical system, everything, etc. In the hospital management series, like management of resources, is there any material left out? Every single thing is being maintained by a records right now. Everything will be intimated beforehand based on the availability and the usage, and it will be very ahead of the diagnosis, the logistic of sampling, transport, etc. In the clinical decision support, the patient provider, patients will be interacting with the doctors, and the electronic records will be collected. An algorithm will give, based on the analyzing of the patient records and the previous records and the general PubMed and every single database, it gives a recommendation, and the practitioner along with the recommendation have their own output out of it. In drug discovery, the AI is being trained with a lot of databases, so it can give a nice targeting tool, targeting samples, the patients of target to be tested, every single thing will be analyzed by here and then. In the public health management, the electronic records, the health surveys, the disease registry, the social media, every single thing can be linked to an AI algorithm, where it can further recommend that if at all any pandemic take place, if at all any abnormality in the regular means takes place, it can be an alarm for that. The cyber security is like the database for safety, and it has been also found to be helpful in that. In the personalized healthcare, I have been saying that the patient's electronic records is being collected, and personalized care can also be given for that. And the areas of expertise where AI is being is that primarily the radiology, followed by the cardiovascular, being the fit bands for the cardiovascular, and the radiology, which is being the main electronic health record which is being available. The CT, MRI, OPGs, and everything is being playing a huge role in that. The global AI market is being found to be highly towards the now we are working on the diagnosis. Later it will be further moved on to the robotic surgeries. So they can diagnose themselves. So they can also work on the surgical part also. It is being going on. So in the clinical trial of the selecting the patients, as I said earlier, is also have a huge market right now. The current statistics says that according to the Journal of American Medical Association, there is a reduce in the missed cancers, like the 50% of the non-diagnosed cancer cases has also been diagnosed, and in Alzheimer's, the accuracy of diagnosis has been increased to about 20%, and the reduction in the time of the new drugs to coming into the market has been reduced to up to 50%, and the hospital readmission has been reduced to up to 10%. This is the software which is being the only software which has caught my attention for the dental purposes, where they have used the WhatsApp as a tool to communicate with the patient, and it is a chat bot where the patients can actually chat with the chat bot and give their images of the oral cavity, and itself creates a report along with the dentist opinion too. So it is the only software which I have come across. Recently, since there are a lot of softwares and a lots of startups taking place, ICMR has given us guidelines on ethical application of artificial intelligence for biomedical research and healthcare. Even this year, GPay, which is like global AI summit, has been conducted in India, and it has been a consensus that we will partner with 20 countries for the benefit of healthcare and agriculture. So coming to the dentistry per se, like dental charting is the primary area of interest, followed by the orthodontics, periodontics, etc. The dental charting is like we are taking an OPG, and if we are inserting the OPG into a software or an algorithm, it itself identify the tooth numbering present, 1, 2%, 1, 3%, and the teeth to be restored, teeth to be filled, the teeth filled, it will be identifying by itself. AI in pathology is like, as I said, I have already worked on a previous work, and this is my one among my work, where the algorithm itself identifies the normal dorsum of the tongue, the lip, the suspected lesion, and ulceroproliferated lesion, everything. We have to just trace it out and train the algorithm with series of images. We used around like 400 images, and we got a nice accuracy. And in endodontics, it also identifies the missed out canals, the root length, every single thing will be apical position, the periapical lesion, and the burnouts, everything will be identified. These are the few systematic review which has been published, and I just mentioned it. In orthodontics, we already know that the Invisalign and other companies have come with algorithms that which can predict the futuristic profile view or the malocclusion to be corrected, everything like that. Like similarly, CBCT segmentation, tooth segmentation, landmark identification, dental monitoring, and the other facial evaluation can also be done using AI. These are the few applications of that. In periodontics, the gingival health, the implant placement, and everything else can also be appreciated. In prosthodontics, similarly, the crown shade, the crown generation, the tooth millimeter difference which will be there, and can also be the dental arch examination can also be done using the AI. In periodontics, the dental plaque, early childhood caries, the pit and fissure sealants, where the dental treatment can go failure, or the dental treatment which might be a extraction can be a right way, or RCT can be a right way. Lot of human errors can take place. Medicines of amoxicillin can be a right one, or an augmentin can be a right one. A lot of things can be a huge game changer when AI comes to the play. This is a summary photograph showing the AI applications in healthcare for a physician point of view of surgical robots, medications, care, clinical trials, diagnosis, prescription, etc. In diagnostic point of view, error-free diagnosis and symptomatic analysis, predictive model, radiology assistant, and diagnosis via medical imaging, like whole slide imaging has been playing a huge role right now, and there are also algorithms developing for those two to assist in the pathologist diagnosis. And in patient care, of proper follow-up and the real-time prioritization and triaging of patients, and pregnancy management and health assistance can be there. And in research and development of ideal selection of patients, clinical trial, drug designing, pandemic alarming, everything has been done. Once again, thank you for giving me this opportunity. My team of oral pathologists, Dr. H.O. Pratibharamani ma'am, and to start with Dr. Karthikeyan sir, my juniors, my seniors, my peers, everyone. Thank you for the patience. Thank you very much.
Thank you, Dr. Dinesh, for the informative lecture on AI. It was good to know about AI via WhatsApp and cyber security and all. Thank you so much. And I now welcome Dr. Simranjit sir to felicitate our alumni, Dr. Dinesh. That's the end of the plenary session. Thank you so much.